Right. Good morning, good afternoon, good evening, good night, depending where you are in the world. Um, uh, Welcome to the hopefully inaugural 24-hour ELSO Congress in honor of course, Professor Bob Bartlett. Thank you all so much for attending. We've got a wonderful 24 hours lined up for you. This is supposed to be a celebration, really, of Bob's zeal for ECMO and his enormous support that he's given us all as individuals, the wider community, and of course, all of our patients over many, many years. He was fascinated by the interplay between technical and clinical innovation. And we know of his enormous enthusiasm for ECMO over his entire career, from the development, of course, of ECMO itself to the support for the major trials, the neonatal trial in the UK, the CSER study, the recognition of H1N1 as such an important element within certainly adult practice, and I'm an adult practitioner, and of course, COVID more recently. Bob's countless support for studies in the preclinical engineering and clinical domain was vital to the spread of ECMO over the years. But he also founded ELSO. He was focused really on the sharing of knowledge, and that's what this is all about over this next 24 hours. Sharing information, sharing expertise, sharing knowledge. Bob not only set up ELSO, but he recognized the global nature of what ELSO has become. He developed the chapters. He was instrumental in supporting the development of Euro-ELSO, AP-ELSO, SWAC-ELSO, and Latin American ELSO. And it's in the spirit of Bob's boundless enthusiasm for learning, his global vision, that we welcome you to this global Congress over the next 24 hours. And a particular thanks to those who've helped me bring this together. Peter Alexander, John Fraser, Rodrigo Diaz, and Ibrahim Fauzi, as well as Christine, Peter, Lauren, and the enormously helpful team at ELSO Central. With that, I will hand over.
Nick, thank you very much. On behalf of ELSO as an organization, I just wanted to welcome everyone here. Nick has said it extraordinarily well. This is really all about Bob's vision. And I was talking to Bob last year. He knew his health was failing, and he was talking about legacy. And what was interesting and very characteristic of Bob is it wasn't about him. It was about the legacy of ELSO and the ECMO community and continuing to innovate and do all of the amazing things that he set us off on this journey for. And that's really what I think today is about. And this is, I think, an extraordinary lineup across the world from all of our chapters and all of our friends throughout the world, honoring Bob's legacy in the sense of carrying on the science and innovation that he spearheaded for so long. And I want to thank, first of all, Nick, for having the vision to put this together. It's a brilliant idea, and I think a wonderful tribute, and again, a nice way of bringing us all together to continue the mission. I want to thank each of the chapter organizers. So Pete Alexander for the US and Canada, Rodrigo Diaz for Latin America, John Fraser for AP-ELSO, Ibrahim Hassan for SWAC-ELSO, and Nick also for organizing the Euro-ELSO portion. And then, of course, as Nick said, nothing gets done at ELSO without the entire staff in the background, Alex, Lauren, Janelle, Liz, Victoria, Peter, and Christine. So I want to thank you all very much. But you're really in for a treat today. There are over 130 speakers and moderators. We have over 2,000 people signed up to hear these talks today throughout the next 24 hours. All about innovations in ECMO technology, novel devices, global collaboration, regional updates, building high-performance networks, and ways that we can use our data to improve outcomes. So I think this is really an extraordinary event that we're all looking forward to, and I hope you all enjoy it. Thank you very much. And I'll pass it off now.
Peter, I think we'll pass it off to you right away. Just a hearty welcome from everyone around the world. We're so thrilled to have this opportunity to just see how the science progresses across chapters throughout the next 24 hours. And thanks again, Nick, actually for having this thought and idea as a way to honor Dr. Bartlett. Peter?
Hi, everybody. Good morning, good evening, good night, depending on where you are in the world. This is such a fantastic innovation. And again, thank you to Nick for having for being the inspiration and making it happen, as well as to all the team at ELSO that have done the work in the background to facilitate this webinar for us today. When I joined the ELSO community, I found an environment which really valued volunteer contributions and fostered collaborations, while individuals within the community were really building better and better science. In the mix was always Dr. B and Wanda. And for those of you who didn't experience this, they'd like walk through the crowd at the end of the night. So everybody was drinking after dinner and having fun. And Dr. B would stop and make personal connections with people and really value shared space and time. He loved a photo opportunity, but anybody who had a photo with Dr. B would also know that he'd ask you your story, and he was really interested in who you were and what you were doing to contribute to this community. And it's kind of in that spirit that we've built out our program for today. I had the honor and privilege of setting up a North American program, which we don't normally do because, as you'll know, our ELSO meeting in North America, in the US, is a global meeting. And so we've always got global contribution. So today, having a stacked program with people just from the US and Canada was a little bit unusual. But as we've already mentioned, we'll follow the sun across the globe. And so after North America come the other regions in sequence, finishing up with Nick's EuroELSO program in the wee small hours of tomorrow morning. So without further ado, thank you all for your contributions and your willingness to participate, and thank you all for those who are watching. I'm very excited to introduce our first session moderators. Joining us moderating the session today, we've got Jay Shiland, who's a healthcare financing executive, an ECMO survivor, and one of our ELSO board members who also contributes as a board member to the Schwartz Center for Compassionate Healthcare. It's been an absolute honor to get to know Jay and his wife Elizabeth as part of the ELSO board, and I'm really looking forward to his contributions today. Christine Stead, ELSO CEO, obviously, where she works tirelessly to improve access to ECMO resources. She influences healthcare policy and the patient, family, and provider outcomes. We all recognize how important and impactful Christine's been to the organization, and it's great to have you a part of the session moderating team today. Dan Brody needs no introduction to anyone, obviously. He's Professor of Medicine, Vice President, Chief Medical Officer of Critical Care at Johns Hopkins, Chair of the Board of Directors of ELSO and ECMONet. President of ELSO, Chair of the Board of Directors at ECMONet. And I'll be joining them, moderating the cast of speakers that we've got today. I'm going to introduce Pearl O'Rourke as our first speaker. Pearl, as many of you know, is a retired pediatric critical care physician, an early ECMO adopter who undertook early clinical trials of the emerging technology, long-term collaborator and friend of Dr. B. She went on to influence healthcare policy, working with Senator Edward Kennedy as a member of the Labor Committee staff before returning to Harvard University as Director of Human Research Affairs. She continues to contribute to clinical research and trial design as a leader of the NIH Pragmatic Trials Collaboratory. And Dr. O'Rourke is also a member of the Board of Directors of ELSO. She's going to get us started today with a talk titled The Bartlett Legacy, Curiosity, Innovation, and Teamwork. Take it away, Pearl.
Great. Thank you. Good morning, all. And oops, this never works. There. I'm trying to share the screen share. Okay. It is an honor to start this off. So hello to everyone. And I think we all know Bob, and I'm going to refer to him as Bob here all the time. But we all think of Bob. Oops, continue to share. Wait a minute. Continue to share. Yes. Okay. We all know Bob as a father of ECMO. And I think the title of this talk really tells us why he earns that. It's a story of relentless and endless curiosity, a focus on innovation, the ability to attract, convene, and sustain groups of like-minded individuals. And I think, as Peter said, when he talked to you, you were the only person in the world, and you were his best friend. We had a lot of best friends. And I would add to this list, it took a lot of courage, tenacity, and the ability to inspire others with his enthusiasm. So, going way back, in his training, and the arrows are, there's Bob. He did his training at the Brigham Hospital in Boston. And he really appreciated the fact that his mentors and his colleagues expected a lot and encouraged innovation. In this very rich environment, Bob coming in with an incredible understanding of pathophysiology and physiology, he approached clinical medicine with a very curious mind, always asking why and seeing what he could learn from each patient. And I think one incredible example is, as a resident, he had a pre-op patient who'd had a stroke. And this patient was breathing at 4 breaths a minute. And he thought, oh man, this is going to be a bad post-op course. Well, the guy had surgery and he sailed through, not a problem. And Bob thought, why did this happen? And as he looked at the guy, he realized that not only was he only breathing 4 times a minute, but the breaths were huge and really so big that they really kept his total lung volume fine. So rather than just celebrating the fact that he got through without a post-op complication, Bob thought, well, why did this happen? And maybe if I could encourage other post-op patients to also take deep breaths, we would decrease the pulmonary morbidity. So what Bob did as a resident is invented the incentive spirometer. I had not realized this until very recently, but again, he did this as a resident, a lot more than I did as a resident. Relevant to ECMO, during his training in Boston, he did a stint at the Boston Children's Hospital under Robert E. Gross. And anyone who was around Bob for more than 10 minutes must have heard some story about Robert E. Gross. At that time, cardiopulmonary bypass was the bubble oxygenator, and the air-gas interface obviously limited the amount of time one could safely be on bypass. And for cardiac surgery, this also limited some of the more complex congenital heart diseases in terms of their repair. And in an oft-told story, Bob basically went to Dr. Gross and said, we need a membrane oxygenator. And what Dr. Gross said to Bob, well, why don't you work on it? And that's exactly what Bob did for the rest of his life. And I think Bob's contributions went way beyond any expectations that Dr. Gross could have possibly had. So again, while he's doing all of his clinical stuff as a resident, he also started working in the lab. And he partnered with Dr. Phil Drinker, who's up in the upper right there, who is an engineer from MIT. And they worked on a number of technical designs, such as this one. And I think one report he was most proud of was in 1968, 2 years before he left his residency. They had actually kept a dog alive for 4 days on partial bypass. So Bob was incredibly busy. He had a lot of balls in the air. After finishing his residency, he moved to Irvine, California. And in addition to his clinical activities, he started a lab, and he and colleagues continued to work on membrane oxygenation. There were others who were also looking at this area. And in the early 1970s, Dr. Ted Colabo, the person on the right there, and actually of interest, the person on the left is Warren Zapal, who we'll talk about in a minute. But Dr. Ted Colabo developed the silicone rubber coiled membrane oxygenator. And the NIH actually patented this device in 1970, and it took a few years for it to sort of flow out to the rest of the world. But Bob celebrated this discovery and quickly adopted this lung for future research and for ultimately initial application. So as Bob was working in the lab, one day in 1972, he receives a call saying that there was a trauma patient that the referring physicians would like to send in for ECMO. Bob felt that at Irvine they were not quite ready, so he suggested that he refer it to Dr. Don Hill, who was in Santa Barbara. And he felt that Dr. Hill was further along and better positioned to start clinical application. So Bob drove the 3 hours up to Santa Barbara to observe. And I think this is a picture of that first adult patient with respiratory failure. And Bob went up to watch and to learn. And as an aside, while many of us use this photo in various talks on ECMO, Bob actually took this photo. It is evidently is the only photo documentation of this early case. And remember, at that time, no cell phones. You had to have a camera. So I think Bob participated more than just observing, but also by documenting. Also in the mid 1970s, Bob helped to design the NIH respiratory failure study, also known as the ZAPAL study after the first author. And NIH funded this study because there were reports coming up of using ECMO on adult patients. And those who were in the study, the investigators truly felt that ECMO was going to be superior. But what happened here, and you don't have to be a statistician to see this, bottom line, they stopped the study early because basically it was showing there was absolutely no difference. And this study had a chilling effect on any future use of ECMO in the adult population. And in fact, many thought, well, that's the end of ECMO. But simultaneously, with looking at doing the study, Bob and colleagues started offering ECMO in extreme situations into neonates. And in 1972, they had their first success with a post-op neonate who had post-cardiotomy cardiac failure. But the case that we all remember is 1975, reported in 79. And this was Esperanza. She was the first successful neonate with respiratory failure. And Esperanza was a newborn with meconium aspiration and persistent pulmonary hypertension of the newborn, which ended up probably being one of the best diagnoses for good survival with ECMO. By the time he left Irvine, Bob reported the use of ECMO in 45 neonates. And this was at the time of VA ECMO, right carotid cannulation, roller pumps, and a variety of home-tailored cannulae. We really did not have ECMO cannulae for neonates. So we had to, most of them made them out of either chest tubes or endotracheal tubes. But you can see the survival rates there were pretty damn good. In 1980, so having spent 10 years in Irvine, he moved back to Michigan. He brought his ECMO team, his neonatal ECMO program, and he started what became known as ECMO School that many of us attended. And almost every time there was a snowstorm. I don't know why. He started what became known as, while at Michigan, ECMO became the expected care in their NICU. And although some new ECMO centers were slowly appearing, aside from these few centers and from Michigan, there was skepticism and in some cases outright damnation for neonatal ECMO by many. Bob felt that the only way to prove the benefit of ECMO would be a randomized study. And because there were so few centers in Michigan had the most cases, he thought it had to be at Michigan. Now, this was difficult to do at an institution where ECMO was already seen as standard of care. So they used a novel study design called Play the Winner. And there's not time to go into all the specifics, but the bottom line of this is that the randomization scheme for each patient or each subject is influenced by the outcome of the previous subject. And what happened here, these were the results of this study. One patient randomized to control and did not survive. 11 randomized to ECMO and survived. At this point, the study was statistically significant, but it changed very few people's opinion. And unfortunately, I think it really was not the data that was needed to push this therapy forward. Bob encouraged much more research, and actually there were 2 subsequent randomized studies in neonates which both proved neonatal superiority. Over this time, perhaps in response to these studies, but more likely in response to increasing reports of success and case series, neonatal ECMO was increasingly adopted. And by 1988, there were 715 cases in a registry that was sponsored by Michigan. Again, this is before ELSO. And since then, we've seen the evolution into pediatrics and back into adults. Now, why did I go through all of this? I think we are here because Bob, this was his story. It was Bob who accepted Dr. Gross's directive. It was Bob who did not give up on ECMO after the failed adult study. It was he who was constantly developing ways of making ECMO safer. He started ECMO school, and who from the beginning recognized the power and the need to develop a community. And it was an international community from the get-go, where we could learn from each other, share successes and failures, and ultimately, in 1989, created ELSO. Here's the charter meeting. And the singular goal of all of this was to improve patient care. Yes, endless curiosity, innovation, teamwork, tenacity, the ability to inspire with enthusiasm. I think that is why ECMO got its relatively rapid rise and why we all are here. So we thank you, Bob. And this the picture on the right here is actually a book that has memoirs from Bob. Bob recorded these in the 6 months before he died. And he also invited a number of people to submit a vignette relating to their experience with ECMO. And this is available in digital format using this QR code. So I will stop there. And again, thank you very much for your attention. And I think this is just a fabulous way to honor an incredible person. Thank you. So can I stop sharing now? Okay.
Thanks so much, Pearl. What a wonderful way to start the morning in the US. Dan was going to kick us off next, but I presume he's caught up. But Ryan Barbaro is going to give us our next talk. He's a pediatric critical care physician, health services researcher, and implementation scientist, associate professor of medicine at the University of Michigan. He leads the NIH-funded ASCEND study, aiming to characterize the one-year outcomes of ECMO-supported children and aims to address the question of if and when ECMO should be initiated in children with severe lung injury. Ryan's a member of the ELSO Board of Directors, past co-chair of PediECMO, and he's going to talk to us today about pediatric ECMO research that changed my clinical care. Really looking forward to hearing you talk.
Thank you so much, friend. And thank you so much for the opportunity to be here and speak to a man who has changed so much in so many of our lives. Truly honored to be here. In terms of research that changes my practice, I think it generally falls into one of three buckets. It answers a clinical dilemma, it introduces a new idea or tool, and it organizes and conveys new meaning to existing research. In terms of answering clinical dilemmas, as Dr. O'Rourke recently showed us, clinical trials are best. And as she reviewed, the UK neonatal trial was really one of the most landmark studies in ECMO, showing that 32% survival for ECMO versus 58%, with a relative risk reduction of 0.55. And then 7 years after ECMO, demonstrating no difference in cognitive level, and actually the conventional group having worse respiratory morbidity and behavioral problems. And of course, this didn't impact my practice because this study was published before I had even reached medical school. But I think it is representative of the really important clinical trial work that can be done in children in the ECMO space. And I think it's a nice segue to talking about trials that I do hope change my practice by answering clinical dilemmas. And as I go through these, you'll notice some that are quite old and some that are quite recent, as well as I'll refer to one pending large-scale clinical trial with that's completed enrollment, but with our results not yet published. And so earlier ECMO could improve neurocognitive outcomes. So this 1985 to 1988 single center RCT enrolled 41 neonates who had an OI greater than 25, but less than 40 for at least 6 hours. This intervention of early ECMO versus late ECMO, which is that OI of 40, the same threshold that was used in that UK neonatal trial, suggested in the early ECMO group, all 22 received ECMO, but in that late ECMO group where they waited until an OI of 40, only 14 of 19 ended up progressing to ECMO support. 2 patients died in both groups. And interestingly, the Bailey Mental Developmental Index was 115 for the early ECMO group versus 103 for the late ECMO group 2 years later. And so this study, led by Dr. Bartlett and others, demonstrated potential promise here of earlier institution of ECMO in a clinical trial. High versus low PEEP could potentially reduce ECMO duration. Again, a neonatal study performed in 1992 across 4 centers showed that a low PEEP of 3 to 5 versus a higher PEEP of 12 to 14 might reduce ECMO by 1.4 days. And then this pilot study, single center, enrolled 30 children and showed no difference in the primary outcome of time spent at goal anticoagulation. Interestingly, did show some differences in thrombotic complications, but is a starting point for us to consider, I think, a clinical dilemma that many of us consider in our practice. And then platelet transfusion threshold of 50 versus 90. The recently published ecstatic feasibility study enrolled 50 children at 10 sites and showed no difference in the primary safety outcome while enrolling within 24 hours and demonstrating compliance with the protocol. And of course, the large-scale titer trial, which is for children less than 6 years on VA ECMO and transfusing threshold versus transfusion for indication, hopes to inform the primary outcome of organ failure from pre-ECMO to post-ECMO, and secondary outcome of neurodevelopmental functional status and health-related quality of life 12 months post-ECMO. And so my hope is that these future results do direct my practice in pediatric ECMO in themes of when to start, how to ventilate on ECMO, our anticoagulation, and transfusion practices for platelets and red cells. But those haven't yet reached a change in my practice but there are other places that have, and here where we introduce new ideas or tools. First, I'll harken back once again to some work done by Dr. Bartlett and Zwissenberger. This is that stainless steel prototype of a dual lumen catheter versus just 5 years later, the developed polyurethane 14 French dual lumen cannula meant to sit in the right atrium that was ultimately distributed by Kendall. I mentioned this because it did actually have impact on my clinical practice when in 2019, children lost the only right atrial dual lumen cannula that was available to them. And there was an increase in our VA cannulation for respiratory failure. A short while later, that same group, Scott Mers, who is now CEO of MC3, helped reintroduce a right atrial dual lumen cannula that has allowed us to return back to those similar thresholds that we saw pre-2019 of using VV ECMO in pediatric respiratory failure. Another place where I hope that this does lead to changes in my practice in the near future was the recently published BEAM study that enrolled from 2019 to 2023, 219 children, and used cross-sectional imaging to diagnose acute brain injury and followed up those children 18 months later using VABS-3. 60 of those children had an acute brain injury, and amongst those, there was a real difference in the GFAP and NFL biomarkers of acute brain injury. And hopefully, these are signals that will impact how we care for children in the future as we think about neuromonitoring. And then research that organizes and conveys prior work. And so here is a consensus statement that really does impact my care of children at the bedside whenever I encounter somebody who has a status post hematopoietic stem cell transplant. These consensus-based recommendations provided a clinical decision support tool for decision-making processes of ECMO candidacy and management. And I use this at the bedside each time that circumstance comes up. Finally, I'll close with something that's a 14-patient qualitative study of children who were an average of 16 years old. And here, this study reflected quotes from children who had survived ECMO, and I'll just read them briefly. There's certain things you don't want to hear when you're in that condition. They're talking about my prognosis in the room. I was fully paralyzed. I could actually hear everything they were saying. I didn't have control over my muscles enough to open my eyes, but I knew my family was there because I could hear. I knew my family was there, so I wasn't scared. The team would obviously get a little frustrated and like impatient, and I'd just start spelling out words. Then I would like forget my train of thought because they would start saying stuff that I'm not even thinking of. So I've certainly spoken in ways that I shouldn't have at the bedside of children. I've certainly valued the presence of families, and I've certainly gotten frustrated at the bedside trying to figure out what an awake patient was trying to communicate to me. But I think these words in their own voice really do help to be a compelling reminder of how I act at the bedside of children. And so, in summary, practice that changes from pediatric ECMO. I hope RCC randomized clinical trials will soon do so. New tools like the dual lumen right atrial cannula absolutely impact my practice. Brain biomarkers may soon. And consensus statements such as those on HSCT certainly have impacted my practice at the bedside. But so has qualitative research in small samples by really bringing voice to those patients. And so, big and small, thank you for your research. It does change our practice.
Thanks, Ryan. I really enjoyed the way you've organized the types of research and how they change your practice. And I have the privilege of introducing Joe Tona next, who has a similar talk, but of course from his perspective as an adult practitioner. Joe is a good friend and a good friend of Elso's as well. He is an adult emergency and critical care physician. He's vice chair of research, Department of Surgery, Section Chief, Cardiothoracic Critical Care, Associate Professor at the University of Utah School of Medicine. He leads an NIH-funded Physiology of Unloading VA ECMO trial, which is aiming to understand the impact of unloading the heart during VA ECMO, to really answer the question of whether unloading the left heart improves survival for these patients. Joe also serves in a leadership capacity at ELSO. He chairs the registry committee. And so for those of you that enter data, Joe's made an enormous contribution making that better for us all. He continues on in his second term in that role, and we're really lucky to have him. Joe will talk about ECMO research that changed my clinical care. Joe, go ahead. You're on mute so far.
Thanks so much. All right, let me share my screen here. Okay. All right, thanks everyone. As was mentioned by Christine, my name is Joe Tona. I'm an intensivist and researcher. And Bob Bartlett was a good friend and inspiration as I became a doctor and started practicing in ECMO and doing research. And so it's a real honor to be here today. My disclosures are that I have a grant from the NIH, and I'm the chair of the ELSO registry. So looking here, one of the first studies that changed my practice was actually the first randomized controlled trial of ECMO in patients. And this is the Zappel study that was previously mentioned. And I think what's important to understand about this study is, this was done in 1979. And the outcome of this study, as was mentioned, it was negative. All patients really in both arms, mechanical ventilation or mechanical ventilation and ECMO died. The comparator between the groups was to take patients who had ARDS and to manage them with conventional ventilation at the time, or to take patients with ARDS and manage them on ECMO with conventional ventilation. And what I really took as the outcome of this was that large volume ventilation during VV ECMO has more potential to harm than ECMO has to benefit. The ventilation tidal volumes that were used for these adult patients with ARDS at the time are ones that we subsequently came to understand through the ARMA trial and through other research, were really directly injurious to the lungs and led to a large increase in mortality of greater than 10%, when compared to what we now call protective ventilation settings, or lung protective ventilation. And so in that trial, if you were using non-protective large volume ventilation, as your ventilation strategy, that injurious effect actually was greater than the potential benefit of the ECMO itself. And so you always have to remember what the potential benefit of your intervention or potential harm of your intervention is, and factor that into how your trial is designed. Second trial that changed my practice was really the Aeolia trial, published by Elaine Combs and colleagues in the New England Journal of Medicine. In this trial, which compared patients who were managed on ECMO with protective ventilation compared to patients who were managed with control with the same protective ventilation but without ECMO, you'll see that that was considered a negative study with a p-value of 0.07. But you'll also see, if you look at the survival curve, that there is a difference between those two curves. And if I'm a patient, I want to be in the red arm, in the ECMO group, with a higher probability of survival, even if the p-value is 0.07 and the difference is therefore not statistically significant by traditional thresholds. You can see, and so the way this changed my practice is that the ECMO arm ventilator settings in this trial established my minimum baseline ventilator settings for patients on ECMO. And in this trial, when patients were on ECMO, they received about 4 cc's per kilogram of predicted body weight compared to the typical 6 cc's per kilogram, or 4 to 6, that adult ARDS patients often receive. And the reason why this is important is because, as you know, without ECMO, when you're at 4 cc's per kilo of predicted body weight, you really cannot effectively remove all your CO2, and you will become hypercarbic. Whereas when you're on ECMO and you have the dissociation of gas exchange from mechanical forces, you are then able to achieve lower tidal volumes. And because in this large randomized controlled trial, all the patients in there received about 4 cc's per kilogram of predicted body weight, I took that, and to this day, take that as the baseline standard of what tidal volume should be for patients on VV ECMO, at least that, if not lower. The second thing is that I took from that study that ECMO confers a survival benefit because, as I mentioned, you look at those lines and there's a difference, but it's less than 20%. That's what this trial was powered to detect an effect size for. And so, when I talk to families about the consideration of ECMO, I don't tell them that, ECMO is going to save everyone's life. I tell them that it does have a benefit for VV for respiratory failure, but that it is less than 20%. So the other study that changed my practice is this post hoc Bayesian analysis of Aeolia. And this one got a little more specific in what the benefit was. And so using a Bayesian approach, it actually showed what the probability of different effect sizes was for the benefit of ECMO compared to conventional mechanical ventilation. And what this really tells me is that I now tell patients and families informed by this that VV ECMO probably confers about a 5% net survival benefit. If I'm really enthusiastic, we could say it probably confers something like an 8% benefit, or even more. If I'm very skeptical, it's probably now closer to 3 or 4. But I think overall, with some amount of equipoise, it's probably about a net 5% survival benefit. And that's taken all together. The next study that changed my practice was a study by Joaquin Arauz and colleagues in Brazil and South America. And this study basically took, it was 24 Yorkshire or 24 pigs that they randomized to different lung protective settings on VV ECMO. and maintained them that way for 24 hours. So they had 6 pigs to sham, 6 pigs to a non-protective setting, which was a larger kind of conventional tidal volume, a conventional protective ventilation, which was a smaller tidal volume, and then the fourth group was just near apneic ventilation. And this was really important because a lot of people for many years in my practice would say if you let the lung collapse down during VV ECMO, it'll never reinflate and the patient will die and you will lose that lung. And this study really demonstrated in animals that was one, just completely false. And two, that it actually resulted in much less lung injury, even compared to a conventional protective ventilation that you would see for patients on VV ECMO. And so this was how it changed my practice, was that apneic ventilation decreases lung injury compared to protective ventilation. And also, kind of taken another way, positive pressure ventilation in injured lung is injurious. And I think this is a really important thing that I try and remember is that there probably is really no safe level of mechanical ventilation, at least for patients who have injured lungs, if not for everyone. And so whenever I put patients on ECMO, I'm really trying to minimize the harm of the conventional ventilation in order to maximize recovery of that person's lung function. And this study really helps me kind of bring that home for myself and for my trainees. The second to last study I'd like to show you was the ECMO CS study published by Jan Bolohovic and Peter Osdahl in Circulation. And as you know, this was a study that looked at patients who had stage D shock, Sky Stage D, and then looked at the difference in outcomes between starting those patients in Sky Stage D on ECMO right away, VA ECMO, versus delayed ECMO. And what we saw here was that was a negative trial with no difference between arms. But again, you can see here, this is the cumulative incidence of death or disability. The ECMO group had a lower rate, at least early on for the first 15 to 20 days of death. And it stabilized out later on in the trial. But again, not statistically significant, but I would rather be in the blue line than in the red line. And what is important also to know is if you look at the baseline characteristics of patients, these are patients who are on norepinephrine doses of 0.5 mg per kg per minute, right? Mics per kg per minute. And then epidoses of 0.2. Now, for those of you who provide those types of drugs in these patients, you know that those are, what we would call embalming doses of these medications. They're exceedingly high. And I would never want to put a patient who is that sick on ECMO. I'd want to do it much earlier. And so how this changed my practice is that, I now believe that ECMO has a small benefit when started for patients with severe cardiogenic shock, Sky Stage D. And ECMO should be, for cardiogenic shock, should be started earlier if you're going to be starting it. Maybe Sky Stage C, maybe Sky Stage B. We don't quite know yet. And then the last one I'd like to introduce were really 3 trials in adult ECPR, which were the ARREST, the PROG, and the INCEPTION trials. And each of these trials was incredibly well done, is an incredibly valuable piece of data. And I think in very few other ways can I think of 3 studies that so perfectly kind of defined for us as clinicians really how a therapy works and how it doesn't work. And some of these trials are negative and some are positive, but they really all 3 are needed to understand ECPR in adults. I will just say that the ARREST trial was a trial of about 36 patients that was stopped early for superiority of the intervention arm. There was a difference of about 40% survival between the intervention early ECMO for patients with out-of-hospital cardiac arrest who had VFib witness arrest, very strict inclusion criteria. The trial ARREST had a few cannulators at one center who all practiced the same way, and that was stopped for superiority. The Prague trial was different in that it also was a single center trial with a small number of cannulators who were doing, the same practice, but different from the arrest trial. The Prague trial had all types of rhythms, shockable and non-shockable, and had about 200 patients. That one, interestingly enough, was stopped for futility, and we'll talk about why and what that actually looked like. And then the third trial, the Inception trial, was done at a diversity of centers across Europe. And that study included a very strict inclusion criteria of VFib cardiac arrest, but had less protocoled and less specified management practices for those patients and a number of different cannulators at different hospitals and different locations. And what we found was that the arrest trial was positive, and the Inception trial was negative. And so from the arrest trial, I learned that for VFib witness arrest in a closed, tightly controlled system, eCPR confers a dramatic survival benefit. Likewise, for shockable, non-shockable rhythms in a closed, tightly controlled system, eCPR confers a survival benefit, though significantly smaller. And then for VFib in a pragmatic open system with multiple providers, like almost all of us have, eCPR does not confer a survival benefit. And so, really, it's understanding that if we're going to have a survival benefit from eCPR, it has to be done in both the right patients and in the right system. And without that, you're not going to get a real benefit from that. And so, with that, I'd like to thank everyone for their time, and Dr. Bartlett for all that you did for all of us. Thanks very much.
So good morning. I'm Jay Shyland. First, I must note that I'm a former adult ECMO patient, actually a patient of Dr. Birdie's back in 2010, and I wouldn't be here without Dr. Bartlett's innovation and that of all of you. And so you're all providing that opportunity to others like me every day, and so I thank you all. I have the privilege of introducing Dr. Alvaro Rojas Pena. He's a research scientist and director of the Robert H. Bartlett Extracorporeal Life Support Laboratory at the University of Michigan. He leads NIH-funded translational research at the intersection of surgery, biomedical engineering, and public health research, which focuses on cardiopulmonary pathophysiology, mechanical circulatory support, and organ preservation technologies. His lab is the embodiment of Dr. Bartlett's relentless and endless curiosity, and it continues Dr. Bartlett's approach to innovation with boundless and infectious enthusiasm. He will share his insights today with a talk on, quote, "From the bench to bedside, the next big innovations in ECMO technology."
Hi, Jay. Thank you very much for the kind introduction. I share my slides now. Okay. Okay, so can you guys see my slides?
Yes.
Excellent. So Dr. B was not only a mentor, but really one of the persons that inspired me the most in the last 20-something years. I shared not only an office with him for the last 12 years, but we share a lot of stories and things in life. When you talk about Dr. Bartlett, I think that it's very important to understand his philosophy and why everything that was done in the lab has an impact in the clinical side. Dr. Bartlett's philosophy has the following core principles. He always wanted to solve high-impact clinical problems. He always let physiology guide the engineers, the researcher, the physician, and the surgeon. For him, a team of multiple people, collaboration was very important. Dr. Bartlett has an energy and a persistence despite any skepticism. I think that if Dr. Bartlett will take the nose, ECMO will not be existent at this time. And finally, Dr. Bartlett always wanted to return anything that was done in the lab to the patient. And most important, it was his legacy. Dr. Bartlett took every single opportunity for teaching and mentorship each one of us. So I created this circle of Dr. Bartlett legacy in research, where we start about ECMO, how ECMO ECLS can transform life and research in the future. So two main problems tackled Dr. Bartlett in the last 40 years. One of them was, can we do ECMO without a pump? And that's what we call the wearable artificial lung. At some point, the group from Michigan and others have achieved steps towards this aim. The other big problem that Dr. Bartlett wanted to tackle was the problems with clotting and ECMO, that interaction of artificial surfaces. For that reason, we created in Michigan what we call the nitric oxide surface anticoagulation. And um, and the future of the artificial lungs comes to Dr. Podke, who has been working at microfluidics and micro lungs. So here we're showing an artificial lung, a capillary bed lung that can support up to a rabbit. And then he's also working on 3D printed microfluidic lungs, which can be the future because the blood interaction is much better. This simulates a capillary of the normal lung. Natural surface anticoagulation is we've been using plastic that are modified to release nitric oxide. Nitric oxide is being produced by your vascular endothelium and multiple cells in your body. My nitric oxide numbs platelets. So what we're doing is coating anything from the cannula to the connectors to the tubing and able to release nitric oxide levels a little bit higher of what the vascular endothelium does. In order to complete the system, as because the ECMO oxygenator cannot be coated, then we add nitric oxide gas using a nitric oxide generator created in our lab with Dr. Meyerhoff and Dr. Laubner-Sorba. With this, we're able to maintain animals up to 14 days without systemic anticoagulation. These are healthy sheep where we have the control, where we observe and documented the most common complication, which is bleeding. And all the animals with our nitric oxide system sustain 14 days of support without systemic anticoagulation. All of this has been funded with NIH grant. We have about $8 million of funding for the last couple of years. Moving along the line of the circle of research is artificial placenta, what we call now premi-ECMO. The lead on this project, Dr. Mikalishka. So we have worked on supporting extremely premature sheep for up to 7 days. We've been able to document jugular vein to umbilical vein support, maintaining fetal circulation. We can show multi-development of organs, lung, brain, heart, kidneys, and liver. We also have developed, based on 3D printed small cannulas to get support of patients that are less than 1.5 kilos. And all of this is with the aim to move this technology to support the sickest patients and smaller patients in the ICUs. We're also working with Dr. Joe Church that now we have a CDH model where we have tested our artificial placenta and compared to standard ECMO support, showing that the maintaining fetal circulation has better outcomes. Again, this is grants that are being supported by NIH, and unfortunately with SBIR, STTRs, which are now in congressional hold for small business grants. Following in this path, I'm just going to make a stop here. 15 years ago, Dr. Bartlett had the idea to use ECMO to support donation. 15 years ago, we demonstrated an increase of 1 organ rescue per patient when ECMO was initiated. That technology is now called NRP. And NRP is now commonly used around the world to recover organs from DCD, increasing the number of organs that are recovered in 1.2 to 1.3 organs per donor. So Dr. Bartlett had this vision 15 years ago now that's been one of the standards for specific donors around the world. The other thing that the lab is working in the last 10 years and continues to work is the concept of organ banking. So here we have our organ perfusion machine. It looks like Arturito from Star Wars. And you can see here our machine allows you to assess a heart. We have a plastic bag that allows us to do echocardiogram. This is a multidisciplinary team. We have Dr. Drake, Dietrich, and Typographer Owens, all of them cardiac surgeons or cardiac intensivists. Our system is relatively simple, is a reservoir with a pump and an oxygenator, where we have a hemofilter for clearance. And then now for long-term support, we're adding plasmapheresis. With plasmapheresis and this system, we're able to maintain a heart for 48 hours. You can see in gray that the swelling and the diameter of the septal wall is decreased or maintained within normal limits when you use the plasma exchange filter. Then most recently, and talking about the last couple of weeks, we were able to prove concept what Dr. Bartlett wanted to do when we talked with him in September last year. It was to prove that we can have an organ banking or organ rehab center. So we took a heart for 32 hours. Basically, we explanted and keep it in cold storage for 4 hours. And we back table and use our 24-hour normothermic perfusion. Then we did a second cold storage. The cold storage time mimics transport from donor to the transplant center and from the transplant center to where the patient is going to receive the transplant. And then at the end, we did a 4-hour reperfusion. In this time, I'm showing the outcome of this 32 hours out and successful heart transplant with enough CPV. So the concept of organ banking and rehabilitation, which was one of the Dr. Bartlett's dreams, continue to give us excellent milestones. Then finally, Dr. Bartlett has worked very close with corporation. He has helped develop the Crescent JV and the Crescent RA, Natilius, and Vital Flow. So as you can see, the circle of Dr. Bartlett Legacy, you can add anything you want in this, but ECMO is transforming life, is transforming how patients have been cared, is transforming transportation, and hopefully one of these days we're going to have an organ banking supported with extracorporeal life technology. I always like to finish when bad things happen. So Dr. Bartlett emailed all of us when we don't have good results. I'm going to read to you. 10 years from now, grateful patients will be alive because the research we're doing. They won't know how or why it happened without complications, but you will. Dr. Robert Bartlett. So every constraint was a problem to understand and a reason to stop. Again, the team was very important. These are pictures with, as Paul was saying, he loves to have fun. Every time for a picture was important for him. Generations were very important. Dr. Bartlett always believed in the persons and the people that he trained, and he let his legacy carry on. He has mentored, and this is the last 10 years of fellows in our lab, all of them with outstanding academic careers. So thank you very much.
Wow. Thank you to all of our speakers this morning. What a fantastic way to start off the Dr. Bartlett Legacy meeting. I'll invite our speakers and our moderators to just jump on your cameras, if you don't mind, if you're available to. And we have, thank you for staying to time, fully 10 minutes of questions. I'm not sure what the facility will be to take questions from the audience, but I'd love to start us off if that's possible. Joe and Ryan, you both spoke really eloquently about different research that has the potential to change clinical practice in ECMO, but neither of you referenced adult studies influencing pediatric clinical care or pediatric studies influencing adult care. And I wonder if that's something that we need to think about, or whether kids are just not little adults and there's no crossover required. What do you think? Ryan, I think you're on, and I don't know if Joe has been.
Happy to take that first. I think there's obviously wonderful opportunity for cross-pollination of ideas, but I think in terms of what's changing your practice at the bedside, I think that oftentimes it's going to be kind of native population studies. I think in reality, so many of these things aren't single clinical trials that move the needle. So often, I think in the space of ECMO, we're actually changing practice ahead of the research being completed. I think about things like the way that anticoagulation has really moved to so commonly um, without anticoagulation, or just kind of VTE prophylaxis anticoagulation in our bleeding patients. And that certainly has been borrowed from the adults, but there's not good clinical evidence, I would say, either in adults and pediatrics that kind of moves that needle. I think, when Joe talked about apneic ventilation, I'd say that that's absolutely standard in pediatric practice in many cases, even if maybe we wish it wasn't. But that kind of allowing of the lung collapse because we're reducing those ventilatory settings to non-injurious settings, and we see that collapse. And I think those kinds of spaces are obviously informing one another constantly, and there's numerous other examples. But I think when we talk about what we do at the bedside, I think oftentimes there's a little bit of a higher burden of evidence.
Thank you. I'm sure there are other questions from our moderators.
I have one that it might be nice to hear Ryan and Alvaro and maybe Pearl also help us think through, and that is, Ryan teed this up as part of your discussion, but in hopes of the ability for us as a community to help influence device development. You noted a pediatric device that was taken off the market, and we know there are gaps in the market for pediatric devices. What can we do together to inspire the development, especially, I know there's challenges getting to something that's a business success. Nonetheless, what can we do from all of your perspectives to help make this, close these gaps where they exist? Maybe
Well,
Ryan, Alvaro, either one. Yeah, thank you.
let me start with this. I think developing pediatric devices is a challenge. And the main reason is the financial interest. However, I think that companies are also interested to help develop this as long as the technology has been moving a little bit farther away. It's not that they're doing all the R&D. So partnering with them, and this one clear example is the double lumen catheter by MC3 and Medtronic, who is pediatric, and they develop it, and it's not really a large market, right, compared to adults, but they did it, and they're working also on developing a pediatric artificial lung. However, I think it's important that the community asks and the partnership start. So I think the clinical side pushing the boundaries is helpful. We are trying to get a smaller cannula, a 6 French cannula. No one is really interested to sell. So we partnered and did a 3D printed cannula, right? So now a couple of other companies that produce catheters and cannulas are interested. One of them is Cook Medical. So that help us a little bit with that side. But again, I think it's important that the clinicians, the champions, ask and get this collaboration to their business partners. Because I think once you have that collaboration, things can happen.
Yeah, I would just add, I think it's the same problem with the drugs in terms of getting the research and the support for dosage, et cetera, for kids. And it might be worthwhile looking at the Orphan Drug Act, which was a number of years ago for more kind of like rare instances where, industry did get some bonus for having some pediatric support. So that might be one area to look at.
That's a great suggestion. Thank you. Ryan?
I think practically the one thing that all of us can really do is when we are at conferences and we see the device developers, just saying how important it is and how meaningful it is. And I think, where those devices do come into play and impact, I think, celebrating and championing those as well, I think is really important on both sides. And so I do think where it's impactful, we should be championing it, and where we need it, we should be advocating relentlessly so that we remain the squeaky wheel.
I will add that philanthropy is also very important. Like recently in Michigan, um, there is a pediatric device development championship or challenge, and it offers some seed funds to develop kind of medical devices in pediatric side, and is supported by philanthropy. So I think that also very important to consider.
Thank you. So, in answer to a question that's really close to our heart, the availability of pediatric devices to best support children, it sounds like we're all advocating for more investment, both from philanthropy as well as the companies involved in tech development, as well as advocating where we can as individual clinicians. And I think, Christine, maybe you could even speak to the advocacy that ELSO undertakes on behalf of the community and the work with regulatory organizations, because I think that that's something that many people who are listening today probably aren't aware of.
Oh, that's a great prompt, Peter. This is something where the data really helps us all quite a bit, and regulatory agencies are used to more now and demanding the use of clinical registries as evidence whether a device is satisfactory, or at least able something they could approve, in addition to more stringent post-market regulatory requirements in other parts of the world like Europe. So we work closely with regulatory agencies on our devices, and that's where the ELSO registry comes in really handy. So that's work that's ongoing all the time that ELSO is doing in at least Europe and the US, but ideally other markets as well. Thanks, Peter.
Not at all. Thank you. There is so much that goes on in the background that people won't necessarily be aware of. But then we've also more recently turned to patient experiences. And Jay, you did just share more than you often share at the beginning of your introduction. And I wonder if there's anything else that you'd really like the clinicians to be aware of from the patient perspective of the recipient of these devices.
Well, given the fact that I was basically asleep in a coma for 6 weeks as part of this process, I don't have a lot to share kind of in the from the actual experience I went through. But in terms of the aftermath, one is we can hear a lot. I had dreams about things I was actually experiencing. So just, one of the comments earlier was that the patient noted they could hear things happening around them. We can hear, for what it's worth. And two, you have a lot of really grateful patients afterwards. And I think the more you can encourage them to be part of an ECMO community as they leave the hospital, whether they be neonatals or adults, one, it helps with the recovery in terms of having similar experiences. I was very fortunate to have limited, if any, really after effects of my journey. But other folks do have, more, material impacts, whatever they may be, despite survival. And I think the more that you can do, and all of you in the fall can do, to actually encourage the community through ELSO or through your hospitals or whatever it may be, for patients to talk to each other and have events together, et cetera, the more the word can get out in terms of the benefits of ECMO, and helping those patients obviously deal with whatever they're dealing with post injury.
Thanks, Jay. Sorry to put you on the spot, Brent. I know Christine has a question for Pearl.
Yeah, sorry, Pearl, but you've been one of Bob's longest friends. And I thought your start to our session today was really powerful. I've had the privilege of getting to know you better and work with you, including assembling and editing Dr. Bartlett's memoirs. But I wonder, from your view, with the moment we're in and with the folks that are joining us from around the world, if there are some things you would really lift up and highlight, much as you did during your discussion, but as a takeaway message for folks today of how Dr. Bartlett lived his life, how he tackled things when they weren't going well, just maybe some thoughts or comments from you that might help, carry his legacy forward.
Wow, that really deserves a very high-level answer. To me, what carries in my mind with Bob is that it was unfailing support. Regardless of what was happening, he was there to help, and he was always available. You could talk about successes, failures, anything, and he would pull you through that. And I know I was in a number of situations where when we started ECMO, I was in the PICU and the neonatologist did not want and didn't even want to think about ECMO. And sort of, creating a neonatal ECMO program in that environment was incredibly difficult. And having someone to call and just say, yeah, you're doing the right thing and here's how you can go. And I think it's the availability. And I think that's one of the wonderful things about ELSO is that, Bob's no longer here, but look at the group of people on this call. And to my mind, if I were still doing clinical care, I would not, I wouldn't hesitate for a moment to call virtually anyone on this call and say, here's the situation. What should I do? What am I not seeing? And I think that is the value. And I think you already talked about the registry, but I think keeping people together. And when Bob did record his memoirs, one of the areas he was most proud of in his life was mentoring. And I think everyone attending this, going to the meetings, participating in ELSO, I think is a huge testament to mentoring. And I think had Bob been a different person, I think it would have taken a lot longer for us to get here. So I will leave it there.
Thanks, Pearl. I am going to take a minute to just thank all of our speakers. I think one of the things that was clear to me at the beginning of my engagement with ELSO was this really was a community, exactly as you mentioned, Pearl, and has been highlighted by all of our speakers and moderators today. It's a community where it really feels like we can make a difference, and we have a lot of fun as well. So thank you all for getting us off started in the right way for this 24-hour, never too much ECMO meeting that's going to follow the globe. You've started the North American session off in the best possible way. Really appreciate it. At this stage, this morning's first session people can jump off their screens and I'll bring on the second session meeting. Thank you. Feels a little bit awkward without some applause or something, but me clapping on my own doesn't seem right either. Thank you, Giles. That's very generous, friend. Next up for session 2 today, the fun's going to continue. I am delighted to be introducing our session moderators, another all-ELSO community crowd. Giles Peake, first up, is a well-known congenital heart surgeon, professor of surgery and pediatrics at the University of Florida. He's a renowned expert in mechanical circulatory support for heart and lung failure, obviously including ECMO. He was PI of the CESAR trial that we've already heard about this morning and was the inaugural chair of the EuroELSO Global Chapter of ELSO. So thank you so much for joining us, Giles. Heidi Dalton is also on our panel today. I don't know, Heidi, if you can jump on screen. Heidi's a pediatric intensivist to start with, and ECMO specialist. She's professor of surgery, Crichton University, and founder and CEO of the ECLS Virtual Advisors. Dr. Dalton's a past president of ELSO and was PI of the NIH-funded bleeding and thrombosis in ECMO study. George Mikalishka, thank you so much for jumping on camera already. He's a pediatric and fetal surgeon at the University of Michigan, where he serves as the Robert Bartlett, MD Collegiate Professor of Pediatric Surgery. He undertakes pioneering work in fetal intervention and research on an artificial placenta to support extremely premature infants. And that work coming to fruition is very exciting to see. And Tom Brogan is joining us from vacation. Tom, thank you so much for taking the time today. He's a pediatric critical care physician and professor of pediatrics at the University of Washington School of Medicine. He's a past member of the ELSO steering committee and was primary editor of the Red Book and ECMO Specialist Manual during his tenure. I'm going to hand it over to you to moderate the session of another 4 fantastic speakers. Thanks so much.
Thank you very much for that introduction, and thanks very much for all my colleagues who are joining us on this session B, and B obviously stands for best. It's my pleasure to introduce Sungmin Cho. He's an associate professor of neurology and surgery at Johns Hopkins University, where he serves as the director of adult ECMO research. His work focuses on monitoring and managing acute brain injuries in patients requiring advanced life support. As an NIH-funded clinician scientist, he leads the Herald Lab in developing innovative bedside technologies for neurological protection. Dr. Cho will get us started today with a talk entitled, "It's All About the Brain, latest insights for optimizing ECMO for neurologic outcomes. Thank you very much, Sungmin.
Okay, I'm trying to, let me swap the screen. Hopefully that looks good. All right. Thank you so much for the opportunity today. So I'll be talking about neurologic outcome in ECMO patients. I decided to focus on a little, really in the setting of Bartlett Legacy, focusing on innovative device that I've been working on. My disclosures, really, I'm going to start talking about how common acute brain injury is, and then rapidly focus on, move on to low field portable MRI of the brain. And of course, I talked about this 2 years ago in ELSA, but there's some recent evolution of the device. So I can give you some update on the newer version of the device that's coming along. Just to start, how common ABI is, acute brain injury. These are the studies we've done over the years using ELSA database. VA ECMO patients, you can see 8% total acute brain injury, ischemic stroke 4%, 2% hemorrhagic stroke, and VV 5% ABI, much smaller than, fewer than VA ECMO, and ECPR much more common, 16%. Obviously, you can see in the graph, ABI has been pretty steady over the years. Of course, the ELSO registry, as good as it is, and we love ELSO registry, it does underestimate the number of ABI. And if you look at clinical studies, meta-analysis of observational studies, retrospective and prospective studies on this topic, you can see numbers are a little bit higher than what ELSO reports. 21% in CPR in this meta-analysis by Dr. McDaddy at UT Houston. And the second paper by Utah Shoskis, he's a stroke physician. He did this paper, 19% ABI in VA ECMO, and VV ECMO was 10%. So a little bit higher than what also reported. And as you can see, when you look at this Kaplan-Meier curve, when you have ABI, mortality is pretty high. So Dr. LaRusso did this study in the past as well, but we replicated that study, showing that when you have ABI, your mortality goes up by 2 to 3 times. And it happens actually early on. So first couple of days, you have ABI, acute brain injury, and then you have dying patients or decannulation, withdrawal life support. Whatever it is, patients with ABI die early during the ECMO support. You can see in the Kaplan-Meier and then hazard function plot on the right side. This is just a summarizing recent randomized control trials. There are more RCTs on this topic, but I just gathered the three largest trials we've had in VA ECMO. Of course, in session trial, we talked about this in the morning or in the afternoon in Europe, Asia at night. But anyways, the leading cause of discontinuation of ECMO is neurologic cause in session trial. An ECLS shock trial, cardiogenic shock, although a lot of patients had cardiac arrest. You can see second leading cause of death is brain injury. And Prague, you see brain death was the second leading cause of death, which is remarkable. And then a second leading cause of a complication, bleeding complication was ICH. So you can see neurologic injury, whether it's hemorrhagic injury and ischemic injury, you have a lot of common neurologic injury commonly occurs in this population. Just wanted to go over briefly on different mechanical circulatory support device, LVAD, which is a long-term, totally different than ECMO, but in a way it's a device research. And LVAD has gone through a lot of evolution over the years, and it's become smaller and more durable. The problem was actually stroke. This is adult LVAD literature, endurance and momentum 3 trial. You can see the endurance trial actually had 20% or 30% of a stroke, ischemic and hemorrhagic stroke at 2 years of LVAD support. And momentum 3 trial, it came out as a 10%, which is remarkably better than endurance trial when compared to second generation LVAD, which is a HERMATE 2. Obviously, everybody said this is apples to orange. It's really not fair to compare this trial this way. So, we did Intermex study a couple of years ago using well-curated database coming from Alabama. When we did a propensity matching more than 6,000 patients, you can see freedom from stroke and TIA was much worse in HFED patient. Head-to-head comparison, we adjusted a lot of confounders here. And then you can see in the multi-phase hazard analytics, HeartMate 3 did much better than HFED as well. Obviously, that led to FDA and Medtronic decisions to take this device off the market. So I think in ECMO, as we go through this different device, as we talked in the earlier session, device gets better. I think it's important to look at this ABI or stroke as an outcome because cardiac device and any cardiovascular disease, stroke is a really, really important outcome in this patient population. And it has implication to market and also compatibility of this device to be in the patient for a long term. So we move on to safe MRI ECMO study. Obviously, what I summarized was how important it is to look at ABI and stroke in these patients. So that was the motivation. How do we monitor this patient? Because obviously, moving this patient is not a small task of the ICU, and then go to different floor for imaging. So portable CT scan has a limitation for ischemic injury. So we decided to do safe MRI ECMO study, which was presented 2 years ago at the ELSO. This is an ultra low field portable MRI, which is a 0.064 Tesla compared to 1.5 to 3 Tesla in the conventional MRI setting. Much weaker field strength than conventional MRI. It is at the bedside. You can see in the picture. This is Chris Wilcox, who was our fellow in the lab, but now is attending in Buffalo. So it's easier to move the patient's scan in the bedside and then do the scan in the ICU. There is a negligible projectile risk, no risk of ECMO components or equipment being pulled into the scanner. It's got a reduced heating and brain imaging only. So the only thing you can do with this device is brain only, not other body organs. And because of this small device in the ICU, there is no need to disconnect life support equipment. Full monitoring is maintained throughout the scan. And this is available sequences, T1, T2 flare, and DWI, and ADC comes along with the DWI. Diffusion-weighted imaging sequence is important for hyperacute to acute ischemic stroke, and flare and T2 shows all the pathologies. Obviously, right now, this technology doesn't have a contrast scan or GRE or SWI sequence right now. Sorry, I don't know why video comes up, but that's the field. Oh, my bad. I think I put the video and then, anyways, it's the SUP portable MRI system. It's a static magnetic field. There's some force that will draw towards the magnet, but not enough to create a projectile safety hazard. And that's why I think I put the video here so you can see. But it's not coming out really well. My apologies. So I'll just go to the next slide. And then they use AI for clearer and sharper images. So ultra low field MRI 0.064 Tesla. Of course, your concern is how's the imaging quality. And what they did was really they used AI software to do noise cancellation, multiple stages during the process, acquisition, reconstruction, and post-processing. And you can see the imaging is pretty clear, and you feel like it's actually as close to 1.5 Tesla. And this is the second version of the portable MRI you can see on the picture. This is a version 2 that came out last year or something like that. It's much more sophisticated version than compared to V1, which was used in safe MRI ECMO study. It's got a larger pore space, rear door opening, higher gradient field strength, better DWI imaging quality, and you can also see visibility at the base of the brain, which was a limitation of prior version 1 MRI. And this is a new sequence, actually, this company also came up with multi-directional DWI, which adds much more clarity to DWI scan and detecting really a small ischemic lesion down to 2.8 millimeter. Of course, that asks a question if this is relevant for ECMO patients or not. Do you want to know about 2.8 millimeter ischemic stroke? That depends on what you are looking for. Obviously, any brain injury can have cognitive issues when they survive. So I do think smaller lesions are helpful, although that may overestimate the number of ABI or stroke in these patients as well, because that will certainly not cause any symptoms when you have that ABI. And just going back to a safe MRI ECMO study, before we actually translated into human, we did preclinical study, and this is a phantom study we did. ASTM is American Society of Testing Material. They require all the devices to go through displacement first and heating testing for any MRI new device approach. So we tested displacement for 24 French, 16 French, 15 French, double lumen, and IABP, and all we measured multiple measurements for each cannula, each device, and then we compared that to gravity force, which was much less than gravity force in all these devices we tested. And the heating was tested, and change in temperature during 15 minutes of scanning must be less than 1 Celsius degree to meet the ASTM criteria. We tested all these different devices, and you can see in the table what much less than ASTM standard. And then we went on to swine model, and we tested or scanned pigs with the portable MRI and no visible motion displacement forces of the cannula, no issues related heating of ECMO and related components. And then throughout the scan, all the pigs, they had hemodynamically stable during the scan. And this is coming all together, safe MRI ECMO study. When we did the multi-center study, of course, only 50 patients, but still quite a bit of work to do 50 patients with new device and regulatory. We had 3 adverse events, 2 minor and 1 major. 2 minor was basically a suction event and transient ECMO flow decrease, which was unrelated. And then 1 major event was a balloon pump malfunction because patient had additional balloon pump in addition to ECMO, and it stopped working 6 minutes into the scan. And it turns out balloon pump was set to EKG trigger. Of course, any MRI signal can create artifacts for the EKG, and that really confused the device, and the pump stopped working. And then we pulled the patient out of the scanner, and we switched to actually EKG trigger, the internal trigger, 75 bits per minute, and then scan resumed without any issues. And this is the primary outcome that we had in safe MRI ECMO study. You can see of 50 patients, ABI was 44%, 22 patients. Most common ABI type was ischemic stroke followed by hemorrhagic stroke. And we did a sub-study on this population, 18 patients who had portable MRI and CT scan within 24 hours. As you can see, portable MRI was much more sensitive to detect ischemic stroke, and maybe hemorrhagic stroke. CT scan was better, but those are only 2 events that we compared. These are the examples of imaging. You can see this is by the way, V1, not V2 scanner. V2 scanner has a much clearer images and sharpness to the images, but you can see V1 is not bad at all. You can see multifocal stroke in the DWI, ADC correlation, and flare hyperintensity. And this was a ECPR patient who had TTP and arrested. Just to summarize what has been scanned and what hasn't been scanned, this is a constant evolution of this field. You can see VA ECMO, peripheral, central, and VV ECMO and pediatric ECMO has been studied. Swan guns, we actually published this data a couple years ago. Balloon pump also was published, and EKG lead, chest tube, and ventilators. These are all safe with portable MRI. And with caution, successful with portable MRI, epicardial pacing leads. We're actually actively working on this paper. Pacemaker, defib, we have done that. Conditional spinal cord stimulator. Actually, I have not done that. This is other centers, but epicardial pacing leads, in my experience in our shop in Hopkins, when there is pacing, actively pacing, we don't do it, but it's not actively pacing. It's totally safe to do the scan. And we're still trying to figure out if we can scan this patient when actively pacing. We did a preclinical study on HERMATE-3 and Impella. There were issues with these patients, so it's not safe to scan this patient with the portable MRI. And this is a pediatric neonatal study that was coming out of Children's Mercy, Missouri. And you can see safety, and also neonatal pediatric ECMO patients can be safely scanned, and you can detect brain injury early on. More than a third of these patients were scanned within 24 hours in this cohort. So I want to conclude with ELSO guidelines. So we recommend early neuroimaging. This is a guideline came out in 2024 with Dr. Lorusso and also Akram Jakak. And early imaging is recommended by the ELSO guidelines, and we provided some schematic and guidelines what to do for the neuromonitoring and scanning. We did include the portable MRI here. Of course, this is not global yet. But my guess is as people use portable MRI more and more, this may become widely available worldwide over time. And this is just a reference that the guidelines we have done. Conclusion is ABI is a major outcome in patients with ECMO, leading cause of high morbidity and mortality. Early imaging is always important, and portable MRI gives some opportunity, or a really good opportunity, to scan this patient early on during the ECMO support, so we know what to do with the acute brain injury, or especially hemorrhagic stroke, what to do with anticoagulation in these patients. That's it. This is our lab. Thank you so much.
Thank you very much, Sung-Ming. And now Thomas will introduce the next speaker.
Thanks, Giles, and thanks to the organizing committee for asking me to have this honor of participating. I had the good fortune to introduce my friend Lakshmi Raman, who is a pediatric ICU doctor and professor of pediatrics at UT Southwestern Medical Center in Dallas. And she is the medical director of the ECMO program there and has been for some time now. She is also an NIH-funded clinician with a research focus on neurocritical care. Specifically, she investigates mechanisms of neurologic injury in developing predictive models for patients on ECMO. She has been a past member of the ELSO steering committee and was a former chair of the publications committee. As such, she revolutionized the development of publication of ELSO guidelines. Dr. Raman will present the talk. It's all about the brain. We can do better to optimize pediatric neurologic outcomes.
Thank you, Tom. Can people see my slides?
Not yet.
Not yet.
Not yet. Okay, give me 1 second. Let me just share my screen. I'll actually do this.
That looks good. Nope.
Now, but I think you're seeing the present.
There we go.
Is it the presenter view or?
Yes.
Now, is that better?
That's perfect.
Okay. Thank you, Tom, for the very kind introduction, and to the ELSO Leadership Organizing Committee for giving me this opportunity to talk about the brain, which is a topic that's very close to my heart. These are my disclosures. So what do we know regarding neurological injuries on ECMO? This is a graph I made from the complication trend that is reported in the ELSO registry. And as you can see, the complications trend has not changed much over the last decade. And these are some of the complications such as ischemia and hemorrhage that have been reported since 2017 to 2018. You can see there is an increase in the seizures by EEG. That may be because more and more patients are getting monitored by EEG, and that's probably one of the reasons. Similarly, this is a complication trend seen in the neonatal population. And you can see once there is more granular data, it seems like there is a much larger increase in the percentage over the years. But we do know that the percentage reported in the ELSO registry is much lower than single center studies, both from our own and other single studies, and from a recent multi-center data that we have that I'm going to share. So this was a study that was done by one of our ex-fellows, where we looked at neuroimages from 2010 to 2017, where we started doing routine neuroimaging. And we had 105 MRIs and 28 CT scans, and we scored them by a previous method that we further validated. And we showed that actually about 75% of them had some form of injury, of which about 26% of them were significant neurological injury, and we defined significance by correlation with pediatric cerebral performance category scale. And now, dialing up 10 years later, this is our multi-center data. As a part of our study, we get neuroimages from all of the sites, and it is scored by our neuroradiologist. And similarly, in this study as well, we found about 80% of them had some form of injury. 131 were mixed injuries, some of them were ischemic, hemorrhagic, and ventricular dilatation. And the significant neurological injury was still about 22% a decade later. So we have really, what are the risk factors for patients with neurological injury? We know these are some of our sickest patients in the ICU. They are hypoxic, acidemic, they are hypoperfused, and then they are exposed to anticoagulation. They have alterations in intrinsic anticoagulation. They have inflammation and microthrombi. There is loss of pulsatile flow. If you're on VA ECMO, then there is changes in cerebral blood flow and drainage as well. So in 2020, 2021, when I was a guidelines chair, we got together a group of very smart people to bring together a clinical guideline for neuromonitoring in neonatal and pediatric patients. So what was the recommended? We said in the recommended things were head ultrasound if you had an open fontanelle, continuous EEG, cerebral oximetry, and head CT if there were clinical changes. And these were some of the optional neuromonitoring techniques. In the next few slides, I'm going to spend some time talking about cerebral oximetry and continuous EEG and how people have leveraged the data. So cerebral oximetry utilizes the principle of near-infrared light being absorbed differentially by oxygenated versus deoxygenated hemoglobin. These are some of the studies that have utilized cerebral oximetry and correlated them with outcomes. In the last decade, people have used correlation of cerebral oximetry with blood pressure to measure cerebral autoregulation. So one such principle was the wavelet transform coherence, where we, in our group, we showed that using that principle, that the autoregulation index that was higher correlated with neuroimaging scores, and that this autoregulation index was different in terms of if you had ischemic injury versus hemorrhagic injury. So recently, one of our graduated fellows did the same thing, but she asked the question, can I find the vulnerable time period on ECMO? So for this, we had 31 patients who had measurements starting from pre-ECMO. 11 of them had significant neurological injury. And we found that when we looked at the disruption of autoregulation, the significant time period was during the pre-ECMO time period. One of the other techniques is the cerebral oximetry index. Nicholas Durham's group published this initial pilot study where they looked at cerebral autoregulation and showed that the disruption, they had measurements only starting ECMO. They showed that the disruption was greatest in the first day of ECMO, and that there was a significant time spent both in the upper limit, lower limit, and upper limit of the autoregulation time blood pressure ranges. Utilizing the same cerebral oximetry index, Dr. Ethan Sanford, one of our junior faculty now, is working on a much higher cohort, and he showed the same thing that we did with the wavelet transform coherence, that the pre-ECMO time period seemed like was the biggest factor. But however, this could be a biased sample because these are sickest patients and maybe we are monitoring them more closely than the other patients. Moving on to EEG, there are several studies that have looked at the value of EEG in ECMO. This is our own center study where we retrospectively looked over 10-year data. We had 50 patients who had EEG early on and about 19 patients who had EEG within 3 months. And then we scored the severity of EEG as mild, moderate, and severe by previously validated methods and correlated them with neuroimaging. We asked the question, can early EEG predict who is at risk for neurological injury? And we show that when they have severe abnormalities, that there is much higher neuroimaging score by neuroimaging. Recently, this is unpublished data. We have been utilizing quantitative EEG using the PERSIST program. So here we used a multimodal deep learning model where we combined EEG features, the theta and the delta power, with clinical features, including diagnosis, age, ECMO type, and we're using a multimodal model. We have a AUROC for prediction for significant neurological injury of 82.2 with accuracy of 84.4. So far, I have shown only neuromonitoring methods that can potentially detect injuries early. Can we do better? Are there any modifiable risk factors that we can control to decrease the risk for neurological injury? I think across the patient population, we have now shown that early changes in PCO2 from pre-ECMO to on ECMO is associated with significant neurological injury. This was a study led by Neil Shaw where we utilized the ELSO registry to look at this in ECMO, and we show that any drop in PCO2 of greater than 50% was associated with significant neurological injury in all ECMO shown in dark bars and in VA ECMO shown in dark gray bars. And even as much as 30% was associated with significant neurological injury in patients that are shown in light gray bars. So not only was this PCO2, but we also looked at whether rapid change in hemodynamics. So for this, we normalized the blood pressures across the age group, and we show that even increase in blood pressure of greater than 50% was associated with significant neurological injury. So a similar study was done by Nicholas Durham's group using the ELSO registry in the neonatal population, and they showed that there was an overall odds ratio of 1.94 for neurological injury, and in VA patients, not surprisingly, it was much higher at 2.26, and in the meconium aspiration group and under the diagnosis was the highest, where there was an relative decrease in PCO2 across 50% was associated with neurological injury. So the next question is, what do we know about hyperoxia in pediatrics? This is still unpublished data. One of our fellows, Ryan, along with a group of investigators, we have the ELSO registry data, and we asked the question in VA ECMO patients, is there a cutoff? And it seems like around 250. If it is greater than 250 at 24-hour PaO2, it has an odds ratio of 1.27 for the risk of neurological injury. So I think the current state of the field is that ECMO is being increasingly used and in more complex patients. And so with complexity comes the complication in standard neuroprognostication because the patients have prolonged duration of sedation. And all the non-invasive measures of cerebral autoregulation that I showed are currently only in retrospective nature, and we don't have anything at the bedside. So there is a critical need for predicting who are the patients at risk, for early diagnosis of injury, and for protective neuro strategies and interventions. So I'm going to leave the people with the last slide. There is some food for thought. So I think based on both our wavelet transform coherence and Cox index, we show that the pre-ECMO period seems to be very vulnerable. So should we consider cannulation early in high-risk patients? Then that brings us to the question of how do we identify patients at high risk? And that is the current NIH study that I have, where we are working on a prediction modeling, and hopefully I'll come up with the deliverables at the end of the grant. And then should we come up with potential guidelines for modifiable risk factors, i.e. drop in PCO2, hyperoxia, and then also some guidelines for neurosurgical interventions. In our own group, in the last few years, when we had significant neurological injury, we've been able to convince our neurosurgical colleagues to do interventions so that we can improve their outcomes. However, that is not standard across, and I know it is very difficult to work with our colleagues to get them to do that. And so should we have some guidelines? And interestingly, in our multi-center data, even though we had significant neurological injury of 22%, there was 77% survival. So which then brings the question of a structured long-term follow-up. So I'm going to leave people with the thought that I think we are gone from the days of just saving patients' lives with ECMO, but giving them a quality of life and having a good long-term outcome. With that, I will thank the organizing committee and thank the patients with whom I have learned a lot. And I'm happy to take questions in the end. Thank you.
Thank you so much, Lakshmi. And now Dr. Michalitska is going to introduce Dr. Phil Mason. Thank you.
Thank you, Tom. It's my pleasure to introduce Dr. Phil Mason, who's a professor of anesthesiology and the medical director of the Cardiothoracic and Transplant ICU at UT Health San Antonio. His distinguished 20-year military career in the U.S. Air Force included leadership as the adult ECMO medical director at Brooke Army Medical Center. Dr. Mason actively contributes to ELSO's educational mission through sharing his expertise in hemodynamic support and clinical decision-making for patients requiring advanced cardiopulmonary life support. Today, Dr. Mason will present the talk, Leveraging ECMO to Desedate and Rehabilitate.
Hey, good morning, everybody. I assume you can see my slides okay here. You guys have been treated to a steady diet of hard science and research studies, et cetera. I'm going to shift gears a little bit and include some of that, but mostly focus on some practical tips to achieve awake ECMO, or what we've termed ECMO 2.0. So this is what we're all trying to get to. This patient on the left here is femorally cannulated VA ECMO. This is severe pulmonary arterial hypertension with a bridge to basically initiation and optimization of medical therapy. In the middle here, this is veno-venous ECMO, FEM-FEM configuration, bridge to recovery during COVID. And on the right here is end-stage interstitial lung disease, bridge to lung transplant using an RVAD, a 2-cannula approach rather than a dual lumen approach. So this is the goal for most of us when we go on ECMO, whatever the indication or whatever the patient population. So the question is, how do we get from here to there? This is what most people think of in an ICU. It's a very dark place. There's a lot of very passive patients, and we're doing a lot of things to those patients, but they're not doing very much themselves. They're surrounded and poisoned by these, most wanted items around the periphery you see here, propofol, some benzos, some opiates, and all those things kind of stand in our way. And so I've kind of broken that down the way I think about it. The things that stand in our way of getting from the deeply sedated patient to the awake and ambulatory patient that we're all trying to get to. And it comes down to these things right here that all exist really in a pretty vicious circle. Starts with delirium in all of its different subtypes. Of course, we stop sedation because we're trying to wake the patients up. And the first thing they do is get agitated. Maybe they wake up in restraints and they're struggling against them. That's followed very quickly, in many cases, by hypoxemia and circuit chatter. You guys have all seen this. Sometimes there's vent dyssynchrony if there's a ventilator in play, et cetera. And what that leads to is initiation of sedation again, at which point the cycle just starts over. And we never get out of this. In fact, we tend to just spiral down and it continues to get worse. So what we need are some ways to have off ramps out of this cycle. There's a whole bunch of them. We could do a whole conference on the topic alone. But in the interest of time, I'll just cover a few little things here. And I'll say the first one is just making sure you have adequate ECMO support to get through those challenges. And I'll focus, there's a lot to that, but I'll focus right now on drainage insufficiency. This is an animal study, of course, or model. And look where those three arrows are at here. And when the video starts, you're going to see some little kind of dimples there. That's a multi-stage drainage cannula inside of that vena cava being suctioned into the side of it. And so this is what is happening inside the patient when you're seeing chatter on your circuit externally. Obviously, this is not going to be conducive to our goal of awake. A little more about that. This is you see a multi-stage drainage cannula here, and then there's an MRI study here that shows fluid in motion in black, and as it gets less and less black, there's less and less fluid in motion. And that image on the right there is a mock-up of a multi-stage cannula, and everywhere there's a horizontal black arrow is a side port in that cannula. You see a lot of black flow at the bottom, a little bit more up through these, say, first three holes. But after that, there's very little flow visible, which tells you this. Most of the flow in the multi-stage cannula comes through the bottom few holes. This is a case report in the medical literature. The citation's at the bottom there. You see in the left femoral vein, a large bore multi-stage cannula that has exited the vasculature. This is a really cool picture if you're talking about complications of cannulation, but that wasn't the point here. The title of their case report was "The First Holes Get It All." And the point they're making is this circuit actually flowed quite well. Again, because this lowest hole was intravascular and that was adequate to sustain flow. So here's what I would consider a pretty poorly positioned venous drainage cannula. This cannula has some radiolucent gaps where there's multi-stage holes. Okay, these gaps are probably going to flow, or these ports are probably going to flow okay. Though I will say in the lower portion of the vena cava where they're positioned, it's not optimal. It's very collapsible. But what about these lower holes? Remember the ones that get all the flow? These are well below the confluence and they're sitting in the iliac vein where they're probably closely approximated to the sidewall of the vessel. This is going to work great as long as the patient is lying flat, sedated, perfectly synchronous with the ventilator, et cetera. As soon as this patient coughs, breathes deep, starts to move, et cetera, you're going to get nonstop chatter and you're going to be stuck in that same cycle. So avoiding drainage insufficiency is a very ECMO-specific, very, very important intervention to ensure that we're able to get our patients awake. All right, so I guess another point about that is how do we define inadequate support and how do we approach it? And do we need to maybe adjust our expectations and maybe our support's more adequate than we think sometimes? This is a really cool little study published by some folks, I believe from the UK, some physicians who climbed Mount Everest. And I guess in the midst of all that training, they had time to collect their own arterial blood gas samples throughout the trip. And here on the right, there's only 4 of them that made it to the top and had a Sherpa available to carry the sample down the mountain. And if you look, the average PO2 was 25 at the top, saturation 54%. But despite going up the side of the tallest mountain in the world, their lactate was only 2.2. So they're not anaerobic. Of course, they're having some adaptations in place, but they carried a backpack up the side of the tallest mountain in the world with saturations of 54%. So our patient can probably walk around the ICU with a saturation of 84%. I'd also point out their main adaptation was an increase in hemoglobin up to 19.3. And of course, we need to mention this here. There's a lot of debate about when we should invoke the tool of increasing hemoglobin, but the physiology is really not up for discussion. It is crystal clear that if you double the hemoglobin and all things or other things remain equal, you have doubled oxygen delivery. So you do have a tool in your toolbox to deal with hypoxemia that does not involve deep sedation. And again, a lot of debate about when to invoke this, but it is something that everyone should do. All right, another thing that matters is how we manage sedation. Okay, ECMO is the tool to facilitate this, but we have to do our part. A lot of it's laid out here in the 8F bundle. Many of you are familiar, and I'll leave that to you. But let's just talk about a few things about what we use for sedation and how we do it. First of all, and this is an absolute in my ICU, don't use benzodiazepines. Period. End of story. Never for sedation in the ICU. And you'll be much happier. This just shows the transition to delirium with increasing doses of lorazepam. Generally, if our patients are agitated, getting hypoxemic, we start feeling anxious, we take the benzos for ourselves and our staff so that we can spare the patient their harmful effects. So no benzos, period. Another thing is just how the sedation is managed. This is an old study now, over 25 years old, about daily interruption of sedation. Unfortunately, it's not practiced very widely. For those of you that are familiar with the study, the sedation was not weaned. It was not decreased by some percentage. It was not any of those things. It was outright stop, cold turkey, pause the pump once a day. Okay, very important. And when I look around actually some ICUs in my hospital and other places, I don't see this happening. So really important to stop the sedation cold turkey. Secondly, do not restart the sedation until the patient shows you a reason. Educating your staff on that very simple topic will reap you significant rewards in getting your patients awake. But let me take it one step farther, guys. You might consider this fact that the best approach to sedation might be, in fact, probably, is absolutely no sedation at all. If you don't ever try this, you'll never believe that it works. But I'm finding that more and more patients, probably the majority of patients, tolerate even oral endotracheal tubes with no sedation at all. And so the title of the talk was how to desedate. Once you're in a situation of having to desedate, you've already dug yourself a hole. You're playing catch up. The trick is don't sedate the patients in the first place. So after this conference, most of you are going to go back to your ICUs and start taking care of patients. And I would challenge you, the next patient you intubate, for whatever that cause is, maybe just put them on the ventilator, go to the computer, and don't write for any sedation. Maybe write for dexmedetomidine, or maybe nothing at all, and just see what happens. I think you'll be pleasantly surprised. Now, there's a trick here. If the patient wakes up all alone, surrounded by strangers, tied up in restraints as they often are, they're going to panic. They're going to freak out. They're going to get anxious, and you're going to get in the sedation spiral. So it matters that they wake up to a familiar face if a family member is available. It matters that they don't wake up in restraints. Everyone struggles against restraints. That's not an attempt to extubate themselves that needs sedation. That's a natural human reaction to being unnecessarily restrained. Finally, I'll just show a few more slides here to show, number one, what's possible, and number two, just to make the point that engaging the patient's mind once they're awake, keeping them engaged with their normal activities is extremely valuable and important. This is a patient on ECMO. This is a bridge to lung transplant. Him and his brother play in a mariachi band. That's him playing the guitar there on ECMO. Doing a fine job, I might add. So just remember to engage the patients in normal activities once they're awake. This is the powerful antidote to delirium. And then finally, just other creative things you can do to maintain motivation in the patients, keep their heads in a good space, is frequent visits, getting patients outside. Here you see a family dog that was brought in. That dog is, the family's dog brought into the hospital, patient taken outside to meet them. And then I'll leave you with this. I'm hopeful there's no reps from the Spectrum ECMO company on here, because I think the dog treats sitting on our ECMO pump might void our warranty on our Spectrum pumps. Okay, guys, I know that was a quick coverage of a complex topic, but I'll leave it there and be available for questions at the end. Thank you.
Thank you very much, Dr. Mason. Dr. Heidi Dalton will introduce our next speaker.
Thanks very much, everybody. Glad to be here with you today. Our next speaker is Adam Gatula. He's an emergency and critical care medicine physician out of Minnesota. His research focuses on transforming systems of care for out-of-hospital cardiac arrest through innovative geospatial and expanding the availability of eCPR. He is a leading voice, actually, in advancing pre-hospital and transport ECMO protocols. He's trying to improve survival, and reducing geographic disparities, which are a big problem in access to these life-saving interventions. He's going to talk to us today about ECPR offering the possibility of improved neurologic outcomes in out-of-hospital cardiac arrest. And thank you very much, Dr. Gottola, for joining us this morning. Turn off my camera.
Thanks so much for the opportunity to talk with everyone. So as she said, my name is Adam Gottola. I am an emergency medicine and critical care physician at the University of Minnesota, and I'm part of the Minnesota Mobile Resuscitation Consortium. And today we're going to take a few moments to talk about ECPR and how it can improve neurologic outcomes in out-of-hospital cardiac arrest. So out-of-hospital cardiac arrest is a big problem in the United States. As the third leading cause of disability-adjusted life years, over 350,000 patients will experience a cardiac arrest in the United States each year, leading with a survival to out-of-hospital cardiac arrest discharge rate of 9.3%. Now, standard resuscitation strategies are often insufficient in cardiac arrest patients, and past 30 minutes, the survival is grim for patients, even patients who have shockable rhythms and bystander CPR. Now, fortunately, the ARREST trial, which was a single center randomized control trial, which randomized patients in ventricular tachycardia or ventricular fibrillation to either ECPR or VA ECMO while in cardiac arrest versus the standard of care that was conducted here at the University of Minnesota, provides us with some significant advances to treat this population compared to our standard care. So the ARREST trial ultimately demonstrated both a statistically and clinically significant improvement in survival to discharge, with survival to discharge rate of 43% in the group that was treated with ECMO. And that's compared to a survival of 7% or 1 of 15 patients in the standard group. Now, the study was terminated early through a preterm analysis by the NHLBI's Data Safety Monitoring Board. And this was for the probability of ECMO superiority. It should also be noted that in the ARREST trial, the survival was maintained at 6 months, and there weren't any unanticipated adverse events. Now, this is further supported by a pooled analysis of both the ARREST trial data and the Prague out-of-hospital cardiac arrest study data. And when we look at all the patients who had initial VT or VF in these two studies, we can see a consistent effect shown across time to implementation. And this consistent effect shows a statistically significant improvement of survival probability of 20 to 25%, whether someone was cannulated at 30 minutes or they were cannulated at 120 minutes. And so taken together, these two studies demonstrate, a survival for VT and VF patients of 43 to 47%. And this is ultimately what led the AHA to give a 2A recommendation for ECPR in patients in out-of-hospital cardiac arrest patients that are refractory to ACLS when they're within an appropriate system of care with appropriately trained individuals. And so when we look at the study, we know that there is a consistent effect across time. However, it's important to note while there is that consistent improvement across time, the absolute survival is still different. So the earlier you're cannulated for ECPR, the better your outcome is going to be. And so when we look at all the patients cannulated under 30 minutes, we see an 100% survival rate. Whereas when we look at those cannulated over 45 minutes, we still have that absolute improvement of 20 to 25%, but the survival goes down to 37.5%. And the challenge is that hospital-based cannulation limits early cannulation, and that most patients are then cannulated after 45 minutes, given the restraints of the current system of care. We see this when we look at all of the patients that we have done in our program here at the University of Minnesota. When we look at all of these patients, the time to reperfusion is a big predictor of survival. In fact, again, most of our patients survive if they're cannulated before 30 minutes. However, after 30 minutes, we see a 2.5% mortality for every minute that they are not cannulated. So after 30 minutes, survival significantly decreases. And so the timeline from out-of-hospital cardiac arrest to implementation of ECPR is incredibly important. And how we minimize that timeline is how we can ultimately continue to improve outcomes and ultimately reach as many patients as possible. So if we want to get someone on ECMO within 60 minutes and we account for EMS arriving to the scene, evaluating the patient, ultimately packaging the patient for transport, this really only leaves a 15-minute drive time to get to an ECMO center and ultimately initiate ECPR within that 60-minute window. And so when we look at all of this, only 12% of patients that we may consider clinically eligible for ECPR actually get ECPR or are offered it because they are outside of an eligible geographic space. The geographic location of their cardiac arrest precludes them from being an ECMO candidate given the proximity to the center. And so we see significant geospatial disparities in the United States population relative to ECMO centers. So that causes us to, ask the question, how can we use advanced systems to really reach as many patients as possible and reach them in as quick of a time as possible to, offer this offer this therapy to more patients that need it, but also to improve the outcomes of the patients that are already getting it. And so we can look at different innovative models, such as pre-hospital models that might increase our drive time, or we can add on a helicopter EMS service to that pre-hospital model to even further expand our geographic space. And so when we look at these different systems, in the current hospital-based system, as we said, 12% of clinically eligible patients have access to care. If we change the model to a pre-hospital model, this then allows us to reach nearly 28% of patients. And then if we look at a pre-hospital helicopter EMS-based model, we can reach nearly 50% of patients, and this is without adding a single ECMO center, just expanding the access of the current ECMO-capable facilities. So how does that translate to how our system in Minnesota has evolved? So the Minnesota Resuscitation Consortium started in 2014 at the University of Minnesota Medical Center. In 2019, it then expanded to 2 other local medical centers, allowing for a rendezvous model. Again, expanding the drive times by adding different locations that as cannulation centers. There was an interim pause for COVID, and then in 2022, subsequently, the mobile ECMO truck launched as a pre-hospital solution to initiate ECMO. We have then subsequently added additional hospitals to expand the rendezvous model. And then most recently, we have begun using a helicopter EMS service to reach our rural hospital colleagues, as well as beginning to pilot a pre-hospital program. And so this is what the evolving geographic coverage looks like in the Twin Cities. The light purple drive times are the 30-minute drive times from all of our rendezvous sites, including the rendezvous sites we reach via helicopter in rural Minnesota, with the dark purple being the 15-minute drive time. On the left side, you'll see the 30-minute flight time of our helicopters. So once we are fully pre-hospital capable, we will see quite an increased coverage of rural Minnesota, reaching many areas outside of the Twin Cities. And so with increasing the different modalities that we are able to offer ECPR, we have seen the volume increase quite substantially. And so last year in 2025, our group did 340 ECMO cases, of which 210 cases were ECPR. So, certainly an optimized system can lead to increased volumes and increased access. And that is ultimately what is going to lead us to investigate what we're calling the time trial. And the time trial is a trial that is going to look at pre-hospital cannulation at the scene of cardiac arrest versus cannulation at an ECMO center. And what this is going to help us do is it's going to help us evaluate the independence of time on outcomes, because the patients cannulate at the scene, our goal is to cannulate them within under 40 minutes, whereas currently we are cannulating patients just under 60 minutes. And so if we see that we are able to successfully cannulate patients under 40 minutes in the pre-hospital space, we should dramatically see an improvement in our survival rates. So, in summary, standard resuscitation for out-of-hospital cardiac arrest is insufficient. ECPR does decrease mortality in patients with VT-VF refractory cardiac arrest. And there's a consistent absolute improvement that is independent of time. Hospital-based ECPR unfortunately limits early cannulation, and so the time trial is going to be used to test the independence of time on ECPR in a pre-hospital environment. So with that, I'd really like to thank you guys for allowing us the opportunity to share what we're doing and to chat with all of you guys. Certainly none of this would happen without the work of Dr. Bartlett, to whom we are incredibly grateful. And this is just a picture that I was fortunate to have the opportunity to meet him as a fellow at Michigan. So thank you so much.
Thank you so much for that great talk. And at this time, we're doing pretty well keeping on time. So I'd like to invite all the panelists to come back on, as well as the speakers. And let's ask some questions of the talks that we've had so far. And actually, I'll just start. Based on your last talk there, one of the things I think we have to think about is economics. So how have you been able to fund all this? And are you getting reimbursed for those out-of-hospital cardiac arrest patients at a level that allows your program to remain, financially, fiscally efficient?
Yeah, great question. So, I think we are very fortunate that a lot of the initial infrastructure was supported through both research grants and philanthropy. So the Helmsley Charitable Trust has been very, very supportive of the mission here. That being said, ECPR and ECMO is a highly reimbursed clinical service. And so now our Minnesota Mobile Resuscitation Consortium is a part of the Fairview Health System and is a financially independent entity that is able to support itself. I think part of it is you have to reach a certain volume. And now that we have reached that certain volume, we can financially support our team and our both from the ECMO clinicians to the physicians on call and all of the response vehicles and trucks, et cetera.
Other questions?
Can I ask, I want to ask first of all, these were amazing presentations. I could spend 30 minutes asking you questions. They're so great. But I want to ask Dr. Rahman two questions. One is, do you believe today there's sufficient evidence that in my world, neonatal and pediatric ECMO, should the pediatric patient have the full bundle of neuromonitoring, EEG, NIRS, etc.? And then the second question you put up on your slide, I was thinking as you were giving your lecture, my own bias of early initiation of ECMO. And I'm kind of wondering if we can, if we're thoughtful about it, eliminate some of the pre-ECMO risk factors that lead to neuro injury.
Great question. So if you ask me the neuromonitoring bundle, I'm going to say yes, but also we have to think about the entire globe and what the resources are for people. And we have found EEG to be very helpful. We have been able to identify patients. And I think NIRS, there is still some work to be done as to how do you bring the cerebral autoregulation piece to the bedside in real time. And I feel like we are not there yet. But if you do see drops in trends in the NIRS, along with EEG changes, that gives us a pause, and we certainly hike the patient down for a immediate CT. So what resources are available for your center and how soon you can mobilize them. So that is for the neuromonitoring bundle piece. And then regarding the pre-cannulation, I think we are more and more thoughtful about early cannulation, but I think it is to be teased out. Or is this a biased sample for us because the sickest patients get monitored sooner, and so are we picking the sickest cohort? So I don't know the answer to that. But hopefully the current grant that I have is working on this prediction model, and the way we are thinking is identify based on the risk factors that we have pre-ECMO versus on ECMO. Can we come up with some way that we can identify patients? Okay, if your vasoactive infusion score is X and your lactate is this, maybe this is the time not to wait till this one and cannulate. But I think we have a lot of work to do.
Thank you.
Thank you.
I have a question for Sung Min. We've got a couple of minutes left, so it's going to have to be a quick answer. So early in your talk, Sung Min, you highlighted the difference in the pump design in the VADs, in the LVADs, between HeartMate 1 and 3. the HeartMate 3 with the magnetic levitation and the hole in the rotor was the best. Do you think that there's more we could do with ECMO analysis of the different ECMO pump designs in terms of neurological injury?
Oh, wow. You told me to be quick. So I do I do not know, Giles, but I think that's an interesting thought. Obviously, adding pulsatility into the third generation LVAD, people think that improve the neurologic outcome. And one of the main things that we look at in our lab is to look at pulsatility and how that impacts small vessel injury in the brain. And we have some data on that. When you lose pulsatility in the brain, you lose autoregulation function. So that can cause obviously macrocirculation issue, but microcirculation issue. So that may impact the ABI. So I'll be short here. Thanks.
That was an amazingly succinct answer, and completely agree with you. Thank you very much to everybody. What a great session. We could sit here for hours talking about this, which is, of course, exactly what Bob Bartlett would have wanted. So I hand back to Peter now to continue the marathon 24-hour.
Wow, thank you so much. What a great session. So that's 2 of our 4 sessions representing the North American contributors to the ECMO and ELSO community. Really appreciate all of the effort that the speakers and moderators went to make that session so successful. Next up, we've got session 3, and I'd like to introduce the moderators who will then go ahead and introduce the speakers. I am delighted to introduce one of my mentors, my past chief, Ravi Thiagarajan. He's a pediatric cardiologist and critical care medicine physician here at Boston Children's Hospital, professor of pediatrics at Harvard Medical School. He's obviously got extensive research on ECMO, health equity, and improving clinical outcomes for neonates and children with complex congenital heart disease. And he's a past member of the ELSO steering committee as ELSO registry chair. He co-leads the trial of indication-based transfusion of red blood cells in ECMO, which is sponsored by the Department of Defense. And I'm really pleased that he's going to be here to moderate this session. Together with him, Glenn Whitman is a cardiac surgeon intensivist, professor of surgery and director of cardiovascular surgical intensive care at Johns Hopkins. He's an expert in postoperative cardiac care and quality improvement and has previously served as the chair of the Society of Thoracic Surgeons Workforce on Critical Care. He's got focused research on heart transplantation, ECMO, and minimizing acute brain injury in critically ill patients, and is clearly an expert in ECMO care as well. Thanks so much for joining this morning. Last up, we've got Mike McMullen, who's a congenital heart surgeon. He's professor of surgery and director of ECMO at Seattle Children's Hospital. He's a past president of ELSO and was instrumental in developing international standards for ECMO care. His research focuses on improving outcomes for neonates and children with complex congenital heart disease through innovative surgical techniques and advanced mechanical circulatory support. I'm going to hand it over to you, and you can introduce our speakers. Thanks so much for keeping us on time and for making this such a great opportunity for everyone. Glenn, I saw you come off mute. Are you able to introduce Eddie?
Eddie, whom I've known for decades, but I didn't get the list of people who were talking at my session. So, Eddie, would you please introduce your talk?
Sure. Thanks, Glenn. Thanks, everyone, for the kind invitation to speak. My talk is about an approach to pragmatic research. Okay, I see that Zoom doesn't want me to share. Apologies for that.
So I think on this screen, Eddie, it's underneath the More menu.
Yeah. Yep. I'm just doing that now. Apologies for this. Oh, I just have to come out and come back quickly. I'm sorry for this. I will abbreviate my presentation appropriately.
No problem. I'll introduce you while you're out. I'm sorry, Glenn, that we didn't send you the information, but for those who don't know.
Wait, no, you probably did. I probably just couldn't find it.
That's okay. I can talk. Eddie is professor in the Interdepartmental Division of Critical Care Medicine, the Institute of Health Policy, Management and Evaluation at the University of Toronto. He's a staff intensivist at University Health Network. His research focuses on integrating advanced life support into clinical practice through evidence-based protocols to improve long-term outcomes for the most critically ill adults. He's leading large-scale pragmatic clinical trials aimed at optimizing mechanical ventilation and ECMO for patients with severe respiratory failure. And Dr. Fan will talk to us today about how pragmatic ECMO research is the path to improving outcomes. Thanks so much, and your slides look fantastic, Eddie.
Okay, thank you very much. And again, apologies for the delay. So delighted to be here. It's really an honor to present here at the Bartlett Legacy Summit. I'm going to talk about pragmatic ECMO research. Here are my disclosures. I won't be speaking about any specific devices today. And I just found this. This was the last picture. I think this is the last time Bob actually came to Toronto, met us just before the pandemic hit. And Matteo DiNardo, you could see on the right, was visiting us for a year as a research fellow. And of course, Bob came as a visiting professor to provide his insights, his keen insights on research directions, to give us feedback on projects that our fellows and early career investigators were performing in the ECMO space, and helped us to improve what we were doing. And we cherish the memory of Bob's contributions and obviously miss him very dearly. I think that my thinking about pragmatic research in this space has really been, since the pandemic, the advance of a certain number of ways to think about international collaboration to help forward our thinking and research in this space. One of those is the adaptive platform trial, which really took off during COVID. Here's a paper showing a number of platform trials that are now occurring across the world, where rather than doing individual randomized controlled trials every time you want to answer a question, you create the randomized controlled trial infrastructure that's in place that can then answer either many questions all at once or subsequently answer many questions in sequence without having to build up and then tear down all the things that you're doing. It's a bit more of a time savings, perhaps it's more value, a bit cheaper in terms of using resources to do that. And again, during COVID, this was maybe one of the silver linings of the pandemic, where things like Remap Cap and recovery in the UK really helped us to answer a ton of questions very quickly using this kind of infrastructure. And this kind of planned collaboration has really been increasing since the pandemic. Here's just one example of our adult Bayesian adaptive platform trial called Practical, that's being led out of Toronto, but it's an international and global platform trial. We have 7 domains, 2 of which are related to ECMO type interventions, and 2 of which are related to interventions about mechanical ventilation during VV ECMO. We have 7 active domains across, you could see 9 countries now, and nearly 1,000 randomizations across these domains. And what you could see here is that we're focused on a number of different severity states. And as I mentioned, it's interesting. So we can explore from the spectrum of patients who are not even intubated yet, non-invasive ventilation, high flow nasal oxygen type interventions, all the way up to the sickest patients who are already on ECMO. We're looking at ways to set PEEP during VV ECMO. We're looking at near apneic ventilation protocol during VV ECMO, which I'll talk about briefly, as well as extending the use of ECMO to more moderate patients in this proactive and ultimate interventions. But again, the infrastructure being there to allow us to perform these trials more pragmatically, more quickly, and foster collaborations across jurisdictions. And the other benefit of having an infrastructure like this is the idea of a registry. And of course, we have this outstanding international registry that Bob helped lead, the ELSO registry, which has provided so many insights into ECMO and still is a boon for researchers to use the data that's there. But the registry provides high quality data collection that could be very substantial, again, for this type of infrastructure. And at least in this platform trial, we've embedded a registry that we've created as a complement to the ELSA registry called Index, which provides a bit more granular data to help, again, collect the data that's required. Typically in randomized control trials, it's longitudinal, so collects daily data, has a number of data points that are available for specifically randomized trials. And again, this infrastructure helps us to perform these trials in a bit of a more robust and pragmatic way. And one example of how we've used the registry to embed these kinds of trials is the ECMO rehab trial being led by Lisa Higgins and Carol Hodgson. And this trial actually just finished. It worked across 2 continents, Australia and Canada, using, again, the infrastructure of the registry to perform randomization, data collection, and outcome collection. It enrolled 100 patients as a phase 2 feasibility and proof of concept study about early rehabilitation in ECMO patients. And we're hoping to hear the final results of that very soon. The other thing that you could do is that, again, multiple jurisdictions now are embarked on this journey of creating platforms, and the platforms themselves can actually get together. So rather than thinking that you need to have a platform that spans every global community, every sort of research question, every sort of focus, you can get platforms to work together. Sort of the idea of networks of networks. And again, this was done in COVID quite nicely. One of these examples is here that 3 platforms during COVID, the ATTACK platform that was also led out of Canada, REMAP-CAP, which is an international platform, and Active4, which was an American platform, were all studying anticoagulation during COVID. And rather than having, in the end, 3 trials that were slightly different and not very harmonized, they got together and aligned and harmonized these 3 trials that were ongoing in jurisdictions around the world. And that gave us really almost 1 trial, but 3 platforms to increase our power, increase our understanding, and sort of increase our confidence in the answers that would be provided by that trial. So we have an example of this, a multi-platform trial that we're focused on around mechanical ventilation during VV ECMO. And so we've combined 2 trials. And if anything, I'm not sure what the success of the trials will be, but the names are great. So we have the Romeo trial, which is coming out of the UK, led by Brij Patel, Luigi Camporota, and Danny McCauley, again, examining the intervention of near apneic ventilation during VV ECMO. And we've decided to help them by broadening the ability to recruit patients, again, increase the feasibility by including centers across North America and in Australia with the Juliet trial. And we just, fortunately, being led by Richard Greendyke, which is a fellow from Columbia University that's with us here in Toronto. And we just got funding from that from the Canadian Institutes of Health Research. And then finally, just to touch briefly on the idea that looking beyond clinical trials and being very pragmatic is the idea that we have so many questions to answer in the ECMO space, and we won't be able to perform RCTs on all of them. So this nice editorial led by Luciano Gattinoni showed that if we wanted to conduct a trial to, for instance, look at the efficacy of VV ECMO to confirm the 11% absolute risk difference, it would take over 600 patients. And even with the traditional enrollment rates we had in Caesar and Eolia, would take almost a decade to complete. And we have so many questions to answer. We're going to need some other ways to do that. This is a relatively provocative a commentary from a cancer researcher from New York, sort of suggesting that randomized trials are for yesterday, and we might be able to speed up innovation by looking at other ways, especially observational data. And that's really, again, the focus of the talk, is to be pragmatic. We want to do what we can with what we have where we are. And the idea here is that we now have more powerful tools looking at causal inference that help us to make causal estimates of effect using high quality observational, like data from the ELSO registry, like other disease specific registries that we have around the world. And we can emulate the trials that we want to do when we can't, as a compromise, do the trial that we need to get done. And we have methods around this to do that. Again, in COVID, we had examples where we couldn't get together to do an RCT of ECMO for COVID. 3 jurisdictions around the world did indeed emulate these trials and show very consistent results across the 3 of them, as well as with the previous Eolia trial, increasing our confidence in these things. And the only way to move forward is to do that together. And so just as an example, that we have this collaboration in North America where we've got together like-minded people who are interested in doing research, interested in enrolling patients, interested in answering questions, and we think this will be a helpful way to get forward. One trial that this North American collaborative has just finished is the ECMO-free trial, looking at a protocolized liberation from VV ECMO, led by Whitney Gannon in Vanderbilt and Ricardo Tegeo Paredes here in Toronto. We're hoping to have the results soon. So I think just in the interest of time, I'm going to finish there. I want to thank you very much for the invitation to speak and look forward to the rest of today's virtual summit. Thank you so much.
Thanks very much, Dr. Fan. I'm going to introduce the next speaker. Elizabeth Moore is the Interim Executive Administrator of the Cardiovascular Service Line of the University of Iowa Healthcare and Global Education Director for ELSO. As a pioneer in the field, she's helped establish adult ECMO program at the University of Iowa in 2005 and has since dedicated her career to standardizing ECMO education and training protocols on a global scale. In recognition of her contributions, she was inducted as Fellow of ELSO in 2025. And today she will be presenting and help us understand how quality of ECMO education improves patient care. Liz, thanks very much. You're muted.
Would help if I would unmute. Good morning, and thank you all for joining this 24-hour summit honoring the legacy of Dr. Bartlett. I had the privilege of attending his celebration of life in January, and what struck me the most was his legacy isn't just the machine or the technology, but the mindset he left behind on so many of us, which was the courage to take on meaningful problems. ECMO itself was once a solution to one of those problems we're solving. My own journey with ECMO started a long time ago in a NICU down the hall from where I'm at today. I was a brand new nurse when my preceptor whispered, "Let's go see ECMO." And in the corner of a unit was a tiny baby connected to what looked like a maze of tubing and pumps. And I had never even heard of ECMO during nursing school, yet there were nurses and respiratory therapists managing this incredibly complex therapy. And from that moment on, I was hooked. But the training back then was memorable. 4 days in a conference room, mostly PowerPoint. And then suddenly I was on my first call shift, and my first page was our very first adult ECMO patient at our hospital. The ECMO specialist at the bedside was me, the NICU nurse. Looking back, that experience taught me something so important, and my story wasn't unusual. Around the world, ECMO specialists have been trained in very different ways. And while ECMO technology has advanced dramatically over the past 50 years, the way we train people who run it hasn't always kept pace. So today I want to talk about the next problem we're solving by asking the question, can globally standardized ECMO training improve ECMO patient outcomes? To answer this question, I want to briefly step outside healthcare. In the 1970s, the Ford Pinto was introduced as an affordable compact car by the Ford Motor Company. But the vehicle had vulnerability. The fuel tank was positioned in the very close rear bumper. During the rear end collisions, the tank would rupture and ignite. What investigators later discovered was the problem wasn't just design, it was process and consistency. Assembly procedures and verification steps varied. Training on installation and checks was not consistent or standardized. And even when skilled workers were involved, variability in how procedures were performed created additional risk. The consequences were devastating. The Pinto case became a powerful lesson in safety engineering because it showed something we now understand across many industries. When high-risk systems rely on human performance, variability is dangerous. But that's not the only case. In 1986, Chernobyl nuclear power plant experienced one of the worst industrial disasters in history. The explosion didn't happen overnight. It was a result of inconsistent training and unclear procedures. Operators running a safety test had different interpretation of emergency shutdown protocol. Some knew only partial steps, others learned shortcuts. Alarms were misread or ignored, and ad hoc decisions were made in real time. The result was catastrophic, a massive explosion, immediate deaths, and long-term health effects. Investigators later concluded that a critical lesson, consistent standardized training, and rehearsed procedures could have prevented the disaster. Again, human performance, high stakes, and variability in education can be deadly. So just like the Pinto and the Chernobyl situation, ECMO illustrates the same principle. Across the world today, ECMO specialists are trained differently, different curriculum, different simulations, different competency checks. This inconsistency can directly impact patient safety. But there's a solution. By standardizing ECMO education, building clear curricula, using hands-on simulations, and verifying competency, we can reduce variability and improve decision-making under pressure, and ultimately protect the lives of the patients who depend on ECMO. So after reflecting on my early ECMO training, I realized I wasn't alone. There were others who shared the same vision. ECMO could save more lives if clinicians everywhere had knowledge and competence to use it safely and effectively. Through my medical director, Dr. Bill Lynch, who was serving as the ELSO president during his tenure at Iowa, I connected through the ELSO community. That's how I met Dr. Mark Ogina from Hawaii, who was experimenting with new ways to teach ECMO. At that time, it was some computer-based learning technologies called ECMOJO, and I became one of his research subjects. Soon after, he invited me to develop an ECMO training course that we started in Atlanta, Georgia. And what started as a small experiment turned into a multi-year journey. Over time, we discovered ECMO education enthusiasts all over the world, people independently working towards the same common goal. And in 2018, about 40 international ECMO experts came together And their mission was to inspire, innovate, and influence ECMO education globally. One of the major first steps was defining what it truly meant to be an ECMO practitioner. And from there, we then created 7 focused work groups tackling curriculum, endorsement, certification, online course development, and more, setting a foundation for what standardized high-quality ECMO education could look like worldwide. In 2023, Dr. Janelle Badgelak helped us work to close a major gap in ECMO education by developing the first of its kind international consensus-based ECMO curricula, of which you can find with that QR code. Using a multidisciplinary global panel, we structured a consensus method that was guided by Kern's 6-step approach to curriculum development. We defined core competencies across the entire ECMO life cycle, from patient selection to cannulation and daily development. We also intentionally incorporated complication safety, ethics, communication, you name it, it is all in there, resulting in ELSO's adult ECMO curriculum, which clearly defines what clinicians should know and be able to do across the ECMO continuum, advancing global harmonization of training. In essence, we asked international experts to declare the essential elements that must be taught to ensure comprehensive ECMO care. This process yielded 106 learning objectives, including 32 designed as high impact. Those high impact objectives were subsequently translated into multiple choice questions for knowledge assessment that ultimately has become the foundation of our certification exams, which I'll share in just a second. In 2017, Dr. Bishoy Zachary and colleagues showed that high fidelity simulation significantly improves how critical care fellows manage ECMO emergencies compared with traditional training. He was able to, with this structured approach, to help teams practice and communicate with crisis management, ultimately preparing ECMO teams to respond more confidently and safely in real-life clinical situations. Simulation clearly strengthens how ECMO teams respond to emergencies by building strong ECMO capability, requiring more than just exposure to scenarios. So again, through a Delphi process, we were able to bring together clinicians from a multidisciplinary group, which were able to define the ECMO core essential SIMs, which are listed on the left of your screen. So the first 5 are for the adult essential SIMs, and the last 2 are what are for neopeds. And this allows kind of a safe and reliable way for ECMO teams to practice these high fidelity SIMs, which also integrate into their communication and team work collaboration. We also had a study by Dr. Said, who was aimed at developing a standardized assessment tool for our simulation-based training. And through this, we're able to show that there was significant reductions in times to critical actions in 3 of our 4 scored simulation scenarios. And the authors were able to conclude that the standardized assessment provided a reproducible way to evaluate ECMO training effectiveness and could help improve ECMO quality and patient safety in ECMO programs. And lastly, as I discussed, to round out the full complement of this work, a group put together what we referenced through the use of the curriculum, which is translated into our adult and neopeds EAC and ENPEC standardized international assessment tool, which has been validated through psychometric validation, that allows a way for you to be able to test and understand if someone was able to understand and comprehend all of the learning objectives defined by our international cohort. And so this was kind of the last step of our gap of trying to put together a full complement of training and education focused to try to demonstrate from practical knowledge to simulation to hands-on training, and finally a way to verify the knowledge that they were able to have exposure to. Lastly, we were able to, and what will be kicking off last here this spring yet, we've made the enormous progress on the core curriculum and simulation development, but next we are looking to conduct another Delphi study to look at experienced clinicians across all disciplines with one goal to define clinical competency required for unsupervised management. So not just technical skills, but the full spectrum of practice, clinical judgment, crisis leadership, decision-making, and interdisciplinary coordination. So I share a little bit today to share with you all about the exact study that will be kicking off, and lots more to come on social media, because this has the opportunity to allow for a survey that we hope to hit by this summer, in which we hope will be open to anyone in the ELSO community to chime in and provide their thoughts on what should be included in clinical competencies for ECMO practitioners. I also, for many of you who have looked at our guidelines, what should be coming any day now is our narrative guidelines, or our update to the ECMO training and continuing education. So I know I whizzed through a lot of topics here today, but what will soon be published and available that you will see is kind of the full compilation and story of all this incredible work. I feel very privileged to be able to share this work with all of you, but it's literally the work of hundreds of clinicians around the world, many who I saw on this list joining in today. And so to all of you, thank you for your efforts to be able to bring us closer to having what I would say is a clearly defined global standard in education. So lessons across these high stakes systems seem clear. And so while I can't exactly point to one study that says that ECMO standardized training leads to better outcomes yet, I hope that some of our history lessons can point to us that we don't need a Chernobyl situation or a Pinto situation to recognize that the potential that a standardized ECMO education can bring to our community, and the impact it may have if we were all to really embrace the materials that are being created, and be able to have a way in which we all teach this important technology. Thanks so much.
Thank you, Elizabeth. Fantastic presentation. I'd next like to introduce Steve Keller, a physician scientist, engineer, and medical entrepreneur, associate professor of medicine at Johns Hopkins University. He spearheads innovation in extracorporeal life support technology with federally funded research focusing on the development of next generation ECMO devices, including wearable devices and advanced sensors designed to minimize complications and improve patient mobility. Today, Dr. Keller will discuss innovation in ECMO technology. Steve.
Great, thank you so much for the introduction. I invariably get this part wrong, so let me know if I've successfully shared my screen. Success? Okay, good. Thank you again for the opportunity to talk today. It's a huge privilege. Even more than that, I have the privilege of presenting some of our team's work, and it's a very large team that worked on a recent DARPA project called the Goldovac program. This program is an effort to extend development of an autonomous extracorporeal life support system, really capable of resuscitating in the setting of hemorrhagic shock, as well as providing automated titration of extracorporeal support. The goal and vision of this program was really driven by military needs for early battlefield or very far forward use of life support technologies. The goal of this was to expand capability of the medic in the field to be able to provide advanced care in the setting of active hemorrhagic shock, as well as early lung disease from contusions or other battlefield injury. The challenge with any active warfighting scenario is that a single injured warfighter, especially somebody devastatingly injured, requires an enormous utilization of resources that are oftentimes not present in the battlefield. A single warfighter will, as you can see here under current situation, require multiple providers to care for that patient. The vision of this program was, what if we could expand that capability and allow for a single medic to care for and provide advanced support for one warfighter, and then move on to the next injured warfighter, and allowing for an autonomous system to continue to provide ongoing support of that warfighter. To achieve such an ambitious goal, we had to pull together an incredible team. And I just have the honor today of really presenting their work, the work of a lot of brilliant, talented people. In addition to my co-PI, Dr. Sungmin Cho, who's a panelist on this session today, we also have this really leading lights from the ECMO community, including Dr. Matt Paquetta and rising superstar Ray Okita at Vanderbilt, colleagues, experts in plastics and engineering at Brigham Women's and University of Massachusetts Lowell, and then experts in gas exchange and extracorporeal support, Keith Cook and David Skoog, along with our industry partners from Abiomed and J&J. Our overall solution to this challenging problem was one, development of a novel oxygenator. What we envisioned was a low flow ECMO support system, a new form of ECMO targeting 1.5 to 2 liters of blood flow, really being able to remove substantial amounts of CO2 to provide ventilatory assistance while providing modest levels of oxygen support, recognizing that the battlefield injury oftentimes is lung contusion with a ventilatory impairment up front. Coupling this with a novel catheter, this was really the DARPA hard part of this overarching project. Development of a catheter that was only 15 French on insertion, but capable of supplying up to 2 liters of blood flow at its maximum without injuring the blood. It's something that, again, compatible with both providing support for active hemorrhage as well as sufficient blood flow to achieve gas exchange. And then underneath all of this, automated control, something that really lifted the technical burden and the clinical burden from the bedside medic and expanded capability so that just as we heard the importance of education, the expectation that you wouldn't have the clinical expectation or this clinical experience immediately present at the battlefield. How could we bring with technology some of this expertise closer to the actual patient care in that setting? To develop this, again, we used an automated control system, and our realization of this anticipated that we would have very simplified inputs, things like EKG, pulse ox, blood pressure cuff, but wouldn't have an expectation that we would have more advanced invasive monitoring. What we thought we'd have to develop something that was highly portable, something that could be operated only with batteries and extended for use for hours at a time. And then also have integrated analysis of blood to assess patient status to then automatically titrate support. We developed in a porcine model of severe hemorrhagic shock an automated resuscitation system capable of delivering vasopressors and volume resuscitation to an animal, even despite losing 40% of its circulating volume within a 40-minute period, able to achieve 100% resuscitation rates, even after a delay of 30 minutes. And so this really pushed the goal of having an automated system with very simplified inputs that was impervious, not needing access to internet or other things to drive, but things that we could ultimately simplify with very modest physiologic inputs. Coupled with this, we also then had our automated extracorporeal life support system developed at the University of Vanderbilt by Dr. Ukita and Dr. Paquetta and colleagues that was automatically able to titrate centrifugal pump blood flow through the extracorporeal circuit, as well as titrate sweep gas to achieve the targeted physiological state, as well as achieve targeted gas exchange rates. I'm going to move over the core piece of this because Dr. Cook, Dr. Paquette, and Dr. Skoog are far better able to discuss their own innovation. But really the heart of this work was the pulmonary assist device, their novel oxygenator, which is an extraordinary device, something which we've validated for our purposes across multiple benchtop experiments and then animal work, and something they've been working on for many years. It's really an amazing piece of oxygenator engineering. Coupling with this is the DARPA hard piece of this project, which is to develop a novel catheter. Our visualization of this was a new femorally inserted catheter, our belief being that it's easier to insert a femoral cannula, especially in the battlefield, with less significant clinical expertise than is required, say, for jugular access. And so this required development of a novel cannula, considering that these are not commercially available. We developed a coaxial design with a return cannula that was running down the middle of this, and then an outer withdrawal cannula, all going out to a single connection to our extracorporeal circuit. Excuse me, you see the split connection, but through a single catheter. To achieve this DARPA hard part of the project, to be only 15 French going in, we developed new materials. We used a form of polyurethane called thermoplastic polyurethane for our outer cannula design. This cannula, this type of material is able to have what are referred to as shape memory characteristics. And so we're able to form the catheter at one particular size at a specific temperature, and then expose the catheter to a new temperature, reshape it so it then maintains that shape until it's exposed to its initial temperature. We then created a specific blend of this polymer that went from 15 French. We crimped it down to 15 French. It would stay that at room temperature or when it was inside its external sheath. And then when put into the body, re-exposed to 37 degrees centigrade, it would expand to its 22 French size. Here we had a 20.5 French version, and then we also had a 22 French version. And so here you see the intercoaxial version of the cannula that returns blood flow, and then the external outer cannula pulling blood in. And this form again, allows for a catheter that expands to reduce the complexity of insertion. A key driving component of all of this was to develop a cannula that required no additional steps for the battlefield medic, something that could also potentially be employed to use in the field, in the emergency department, and other areas where placement of smaller cannulas oftentimes is less injurious, but then the cannula can expand to achieve its targeted flow rate. Developing these new materials allows for an enormous range of potential engineering innovations, things that we can do, such as expanding the size of these things, putting in new nanomaterials to change the overarching material properties. There's just a huge range of potential options for those new materials. I just wanted to expose everyone today and take the opportunity here to show to some of the innovation that's coming out that really blends engineering advancements with bedside knowledge and actual clinical use. Our own team depended heavily on Dr. Paquetta's experience in actually doing this in war environments. And so all of this allowed for the development of new ideas and really created a foundation for future innovation. Just delighted again to have the opportunity to speak today and delighted to be a part of this panelist group. Thank you again.
Thanks very much, Dr. Keller. It's a huge pleasure to introduce the next speaker, Dr. Anik, who is a pediatric critical care physician and professor of pediatrics at the University of Toronto and staff intensivist at the Hospital for Sick Children. She's a clinician scientist and specializes in the precarious balance of hemostasis during extracorporeal life support. Her research in the Bartlett Laboratory at the University of Michigan and then subsequently at the Sick Kids Research Institute focuses on blood, biomaterial compatibility, and inflammatory response to artificial circuits, aiming to minimize the life-threatening risks of both thrombosis and hemorrhage in critically ill children. Dr. Anik gave the inaugural Robert Bartlett Lecture at the ELSA annual meeting, and today she will share her insights with a talk. The path to improved ECMO outcomes includes improving anticoagulation. Gail, thanks very much.
Thank you, Ravi. I hope you can see my screen. Perfect. So I have the privilege of giving this talk, which many of you have heard before. So I will go through it from the aspect of someone who has taken a journey in anticoagulation and ECLS and looking at that from that perspective. So I think before I start, and I've said this in a few of my lectures previously, I think this is a really relevant article that many people who've met Dr. Bartlett, spoken with him, and have heard his stories as he stops you. You should read this because it's written in his voice, and it really gives you insight into how he thought about things in a very practical manner, and it gives you it gives you some great memories, is what I would say. I would like to use two quotes as I go through some of this anticoagulation research that I had the privilege to work with him on for many years and continue to have the opportunity to see those others who have taken it over and that I continue to be encouraged to be a part of their collaborations. So using artificial organs for life support and fatal heart and lung failure has grown from an idea to a standard of practice over 6 decades, as has the entire discipline of critical care medicine. It will be fascinating to see where these aspects of patient care will be 60 years from now. And as you heard Pearl O'Rourke speak about the history of things and where it has come to today as she's seen it, having been some of the first pioneers in it. And then just listening to Steve's work and the group out of Hopkins and with Matt Bacchetta and what they are doing, I have no doubt that what Dr. Bartlett's desire was to have an ECMO machine that you could kick under the bed. And with that, you needed to be able to not require any systemic anticoagulation. And so as I look at research in blood biomaterial interactions, I really required very good mentors. And that started with someone taking a chance on me, Dr. Bartlett, welcoming me into the lab in 1995 and giving me a project that I never thought I had any interest in, but now own many books on platelets and anticoagulation and hemostasis, and I can draw a coagulation cascade pretty easily without any extra prompting. And then Dr. Meyerhoff, the collaborations that we had, and pairing me with Melissa Reynolds, my partner in crime, as we wrote grants and created the Starbucks Thrombo Lab Research Planning Committee, which we basically sat at a Starbucks in a monthly lab meetings that we had with this core of people. We got to make decisions and we started to create our experiments. I had the opportunity and have the opportunity to be a good friend now of Marek Radomski, who is just all-knowing in nitric oxide and platelet effect. And really, that really helped to push this research forward. His generosity and collaborative spirit are really important. And then, of course, the Franny Moore effect, which we're hearing from everybody who describes their research groups and how big they are, but they're not just a physician or a clinical provider, but a whole group of people from all fields of research who provide equal voice and are collaborating in this research. And so I really didn't have a lot of an idea of what I was doing with blood surface interactions, but with that positivity and enthusiasm from Dr. Bartlett, he certainly stimulated one to read and to design. He was very patient and supportive, and even if things weren't going well, he was realistic, but still always was there to provide autonomy and support at the same time. So I did eventually succeed in creating a small animal model of extracorporeal circulation when I left my intensivist hat in the clinical arena and recognized I had to create a very robust model of thrombogenicity. And with that, we were able to test a lot of a lot of sort of commercially available surface preparations, which were phospholipid or heparin at the time, and continued to demonstrate that there was some form of systemic anticoagulation that we still required, regardless of what we thought should be better and should not require systemic anticoagulation. And that brought us to think about nitric oxide. And it came through looking at the endothelial cell and then pioneers working on types of stents for both coronary stenting, but also stenting within the liver for other options, and trying to prevent the thrombosis within these stents. What would you create? And there were people like Larry Kiefer and pioneers who started to develop different molecules that would release or elute nitric oxide and prevent the platelets from creating thrombus formation. And we understood all of this through Moncada and Radomski's work about what was the nitric oxide effect on platelets. And perhaps the most unique thing about it is that within the environment of nitric oxide, a platelet is completely quiesced. It's anesthetized. But once you remove it from that environment, the platelet returns to 100% functionality. And that is very unique compared to all of our other platelet inhibitor medications that we even use to date that have some effect and don't return the platelet to 100% normal functioning. So that brought us to the use of diazonium dilates, and this particular compound we called Mahamino was the first, and it was the first one that we would incorporate into a polymer matrix of PVC and basically dip coat it to existing PVC super Tygon tubing within this rabbit model of extracorporeal circulation that we had created. And with that, what we were able to demonstrate was proof of principle, that if you had something that had local release at the exposure to vapor pressure of nitric oxide at the site, that you could stop platelets that were coming past that surface from adhering and from becoming activated and consumed. What was even more interesting was that the nitric oxide surface, without any other types of systemic heparinization, seemed to perform the best and had the best result in terms of effect on platelets. Because once we added systemic anticoagulation, we started to see these amorphous types of partially activated platelets that would occur. And we know this from Hirsch's work on systemic heparinization and knowing that heparin in itself can cause premature activation of platelets. So with that information, this is what Dr. Bartlett and I one day met because we said we do have to write this up. And within a span of about 30 to 40 minutes, we talked about all the research that I was doing and his mentorship. He sat here with his yellow pad and he wrote out the entire outline to the paper, which we then were very successful in ultimately publishing in Critical Care Medicine as a feature article. And with everything that you do in research, you have to continue to search for the right answers. And as we started to look at the chemistry, and our chemistry colleagues started to look at things and further analyze the compound, what we realized was that the entire compound, the entire Mahamino compound, was leaching once there was vapor activation. It wasn't just the nitric oxide that was releasing at the surface. And as a result, once the entire compound releases, the nitric oxide comes off it, we form nitrosamines, which of course, if you're trying to create something that is a better solution than what you already have, where you don't have to systemically anticoagulate, you don't want to impute, or you don't want to put basically cancer-causing compounds within the bloodstream. And so we had to go back to the drawing board and think about different things, including maybe even further simplifying our model, removing the roller pump, because the whole purpose of the model was to create thrombogenicity, not to make it perfect or exactly similar to the clinical environment. Because that would come later in larger animal models, as Alvaro Rojas showed our capability of doing. And the Arriva group out of San Antonio, Texas, led by Andrei Bashinsky, also can demonstrate this now. So this was the model we needed to demonstrate the harshest environment within which we could test these polymers, and we created that. We also recognized that we needed to take more care in how we were dip coating our catheters. And that was more to it than just having your base layer and a releasing layer or active layer, but in fact requiring a finishing layer or top coat to all of this. And so in 2007, we were able to publish the second iteration. Melissa Reynolds and Mark Meyerhoff, close colleagues of mine, and with Dr. Bartlett, we were able to use what we then called DBHD or Norel. And it had butyl groups that made it more comfortable or allowed it to stay within the organic phase of the polymer and not want to leach out. And so that only the nitric oxide molecules were released. And with this increased lipophilicity, we could add other lipophilic additives that allowed us to start to control the amount of nitric oxide release, prevent its leaching, and we could then vary it so that we could decide to start to understand what was that threshold. This was the new model. This was the way that we created it, and we started to call it, and what we called it was a nitric oxide releasing flux. At what percentage of weight, percent of DBHD within the circuitry could we sustain preventing platelet consumption, activation, and adhesion? And so we tested that out, and we were able to identify that really beyond 2 weight percent, from 10 to 50 weight percent, we could preserve platelet function far better than any standard control. We could reduce platelet consumption, and we also had a reduction in platelet activation. So a finite reservoir is what we had created with a top coat layer that required that. And then, you have to look again at your experiment. Well, how can I bring this to the clinical arena? And that was looking at the challenges with how do you extrude this, because the minute you create extrusion under heat, you basically decimate the functional layer that you're trying to create with nitric oxide release. We did many other different iterations. We also looked at silicone, and we looked at other compounds such as charging it under pressure with nitric oxide at times. And one of the most important things was that we basically could reduce platelet consumption. That for sure was demonstrated. The other thing that we understood was that we had significant fibrinogen adhesion. And so with everything, again, Bartlett always warned us, and we heard this over and over again at his memorial service and other things, to not take it so hard to heart that everything was a failure, but to look at this as an opportunity to improve. And we had already started to discuss that it wasn't just inhibiting platelets, but we had to also have a thrombin inhibitor. And at that point decided to put within our active layer, our biomimetic layer that we were creating under for local clotting inhibition, to put argatroban within that. And we were able to demonstrate that proof of principle, just putting the thrombin inhibitor within, and then we combined it. And by combining that polyurethane coating, incorporating both the thrombin inhibitor and nitric oxide, we could create a very biocompatible circuitry, which is now called NOSA, and which Dr. Alvaro Rojas had spoken about some of the work that's being done. And again, an active layer, but with a top coat and with a base layer, and understanding that you needed that in order to make this a functional working circuitry. They have further explored things since I've left Michigan, but I haven't left them in terms of my heart and my collegial collaboration that I hope to continue to have for the rest of my career. They have created a different type of surface, which includes looking at nitrosothiols as an alternative versus the diazonium dialates. Again, how do we produce this? How do we bring it through to the clinical environment? I think, again, there are others working on it. And within North America, I've come to know Andrei Bashinsky. He's become a good friend. And really, I love to see the impact that they are having in Arriva in looking at all of these things. Taryn Roberts wrote this as the first author of this paper, and looking at what the importance of, these biocompatible surfaces need to look like, and all of the challenges that we have. If we narrow it down to nitric oxide specifically, then we need to think about what is the effect of the NO release of the surface properties? What is that effect of that release? Can we control that surface? And if we do have NO release, do we have other protein surface interactions we have to manage? And without control of the surface, then it's very difficult for us to discern. I think the last thing that I have learned is that I had always talked about creating an endothelial-like surface, but we know that the endothelium itself has a variety of very major influences and within illness itself. And so a dysfunctional endothelial state could create a dysfunctional surface if you create it completely endothelial-like. And so if I think about this, trying to control the entire endothelial cell is maybe just more than we need. And certainly it's more difficult than controlling parts of it. And I do believe that the ultimate goal is a patent circuit with normal hemostatic response in the patient, so we can kick it under the bed. And so I'll finish with this statement that Dr. Bartlett has always told us about, and has relevance to everyone who's spoken here already today and will continue to speak, to say that we are all in this type of an environment even now. It's easy to look back and think that there was a brilliant plan, but it wasn't that at all. We started out to solve a problem, then another, and then another. It was just persistence, sticking with a problem until it was solved, with a big team of people, with some phenomenal researchers trying to keep people alive who were going to die. And I see that in all of the talks that have come before me this morning, and I'm sure I will continue to see it through this 24-hour webinar that we have commemorating our colleague and friend. Thank you.
Thank you, Gail. It's fantastic. We'd now like to open up the session for questions and discussion. Unfortunately, Dr. Fan will be unable to join us for this portion, but we have the other speakers who I'm sure will offer some fantastic insight. I'd like to ask a quick question to get things going, and this is of Liz Moore. It's amazing the amount of work that's been done in the education space from ELSO and in general in ECMO. And the one question that always comes to my mind is standardization is so important, and ensuring that we're providing the safest care for the patients is incredibly important. And a lot of the work you've done is standardizing the educational process. But how do we balance the necessity to standardize with the very unique environments, the financial environments, the political environments, the resource environments of different programs throughout the world? How do we strike that balance?
Fantastic question. And I'll say, I'm not sure we've been able to wrap our hands around how to completely integrate all the facets. Really what we set out to do in the beginning is just lay the foundation. And so where we're at today that didn't exist is to have that solid foundation at least. We found that across the globe, what we were stating as what should be curriculum, what should be SIMS, how we should interpret critical action on SIMS, we were pleasantly surprised that when our teams engaged, no matter which part of the globe they were in, we all had agreement. Along the way, we learned terminology that we all use that's slightly different. And so there were even moments of trying to determine, especially when we created the online course, how we express terminology. And many of you are well aware that, that work started with the Maastricht Treaty paper and just standardizing how we expressed ECMO terminology. But I do agree with your posed question of, then when you start, integrating the financials and equipment access and variability in equipment, this becomes a monster undertaking. And I think as Gail just eloquently put in there is, part of this was solving an initial problem, but I think we just keep peeling back the layers. And so you set out to do standardized education, but it's just ballooning into being something that I continue to hope to meet enthusiastic people who will continue on this journey long after my work is complete with it, and have even more talented, bright minds trying to figure out how to pick up this problem and continue to solve it in ways that I probably haven't even thought of yet. But, I am proud of the work that where it's at today, at least, that I think we have that foundational piece of things that across the globe we can agree to, and we'll start hitting some of those harder pieces as we continue to kind of peel this back.
That's great. Yeah, I just I think you're right, and it's what's remarkable to me is to see the evolution of all of these topics. And we start off with a question or an idea, and then it expands and expands, and it's so easy to think, well, we're not where we want to be yet, but it always starts with one step. And I can remember 10 years ago when ECMO education was sort of by the seat of your pants. Every hospital had their own way of doing things. And unfortunately, ELSO has really taken a leadership position in that. And Dr. Bartlett, he had pushed that as a priority from the very beginning. And so it's just fantastic to see that it's come to the point it is now. I just like to ask one more question just related to that. When we embark on research or education or things, it's very easy to go down that path, but it's sometimes difficult to determine how beneficial it is. I mean, clearly there's benefit, but just like in quality improvement work, we're really good at reporting data and putting data in, but we're not quite as good at taking that data back and determining, is it making an impact on our patients? And that's just a universal phenomena. What steps are we taking now to start to look to see what what's the actual clinical benefit to our patients and our teams when we use standardized approaches and we follow the protocols and we go through these educational processes.
Yeah, I think we're just starting to scratch the surface on that. I think that that's what I've often penned as my unicorn study is like finding the exact way to tie what we're doing back to direct benefit of patient improvement. What we are starting to do, and I'm opening Pandora's box by sharing this, but it seems like the right audience to do so, is we're starting to work with states and countries to deploy mass dissemination of the online and or curriculum. If you start talking about thousands upon thousands of people having standardized education in homogeneous populations and states, we can then start investigating and having enough critical mass to start watching if complication rates change. So one piece that I've often set up at night, and again, putting it out there so someone can call me and say, I know how to do this. The essential SIMs aren't arbitrary. If you look at the ELSO complication rates, those SIMs are what those are. And so the thought is, if as a nation, as a country, as now a globe, we have direct actions targeted at trying to mitigate those complications, can we watch over time the ELSO registry in hospitals, in states, in nations drop down with adoption of the standardized training on these critical action steps? It's a giant undertaking, but I'm up for the task if someone can think about how to put our hands around that.
Oh, that's fantastic. Great work.
I can ask a question of Dr. Keller. Fantastic presentation, automizing and standardizing and simplifying ECMO deployment, especially when there are not a lot of monitoring. And I wonder how you think about actual cannulation of casualty and on the field. Have you thought about simplifying that or automating that in a way that one could be efficient at that?
We have, and in our team as a whole, thought extensively about that. For that particular project, it was a little bit out of scope for that work. However, just the intricacies of cannulation, trying to do so in as sterile as manner of possible in an incredibly chaotic environment is incredibly challenging. That's one of the reasons why we targeted on an approach that really attempted to mirror that of a dialysis catheter placement, where the complexities of the connections and whatnot were not as involved. There are other aspects of our circuit that we've developed, things like automated priming and other stuff that also simplifies that and debubbling and whatnot. This work couples with existing Pentagon efforts at developing automated vascular cannulation techniques. And so ours was intended to couple with that. But to answer your question, we really focused on the part of once the wire's in the vessel, where do you go from there? And so we had some novel dilation techniques and some other things that were built into this. But more broadly, you highlight a broader concern of how to move some of these technologies, not just from the battlefield, but then even more generally to the site of injury, whether in trauma, whether in especially as we get into cardiac arrest, whether at the site of arrest, we then start having less experienced vascular access. So how to do that safer? These are all big expanding questions that require a lot of technological development, in addition to enormous efforts in training that have already been discussed.
Great, thanks very much. Don't see any questions in the chat, but I'll ask Gail a question then. Gail, thanks very much for your talk. It's always inspiring to hear you. One question is, antiplatelet agents are never part of standardized anticoagulation. We don't think of them often. Do you think that they should be part of routine ECMO anticoagulation, or should we use them only in specialized circumstances? I'm thinking of aspirin or G2-3B inhibitors at all.
I think what like even what bivalirudin has taught us is that you want something that's not going to have a permanent effect on the function of the platelet. And so, I think aspirin and those types that then affect the lifetime, the entire lifespan of the platelet is probably not a great idea. But I do think there is more out there to consider and to think about. Obviously, taking away your first line defense of primary hemostasis is the scariest part of it. But kind of looking, if we can't create a surface that does that, looking at something where we can create, where people are putting like nitric oxide in the sweep gas, but you have to put a pound of it in there in order to really affect that vat of blood that goes through an oxygenator. So it doesn't quite do the job and you get some toxic effects. Once we can spin that down a bit and create it maybe just at the surfaces, and just have it within the circuitry somehow, a short-lived even, infusion of something that doesn't affect the lifespan of the platelet. The thing is that we use citrate, obviously, in hemodialysis. So we say that works really well because you get local anticoagulation of the circuit and nothing downstream. And that's great, but you only get about 80% functionality back of the platelet because you're still extracting calcium out of the platelet cytoplasm. And so if we can get something that just has, a nitric oxide type effect, and I think it likely is going to be nitric oxide, but something that can just do it within that environment, I think we're going to get to where we need to be. And we're not there yet, but we're close. And I think we're doing far better job because we've cut down our circuits and we have better technology and tubing now that is more slick, and we have a lot less to worry about in thrombus formation, but I think there's still more to do. I do think if you can create something that's short-lived like bivalirudin, that you can reverse the effect almost immediately, that's what we need.
Thanks very much, Gail.
Well, thank you. We could speak about this forever. It's such an interesting set of topics. Unfortunately, the time for the session is ending, and we're going to send it back to PETA.
Thank you so much. What a great set of speakers. Very much appreciate your time today. And thank you, team, for professionally moderating. We're on to our fourth and final North American session as part of the move across the globe in this 24-hour Bartlett Legacy meeting. Thank you for keeping us on time and for everybody arriving at the times that they need to be here. It's absolutely huge. I will introduce the moderators for the next session and then have them introduce our last set of speakers for North America. Justin Sleesman is here with us today. He's the chief perfusionist at Mary Bridge Children's Hospital. He's previously served as the lead perfusionist at Stanford Medicine Children's Health. He's a known expert in pediatric mechanical circulatory support, and he's focused his work on optimizing clinical outcomes for neonatal and pediatric patients. I met him when he was a member of the ELSO steering committee as perfusion chair, and he's a prominent educator who's recently served as subject matter expert in developing the National ECMO Specialist Certification Exam. Thanks so much for being here to moderate, Justin. Jonah Rubin's also joining us. He's a cardiopulmonary critical care physician at Mass General Brigham. He's assistant professor of medicine at Harvard Medical School, and his clinical and academic work centers on the intersection of ECMO, mechanical circulatory support, and clinical ethics. More and more important as we move into the technology space that was just detailed in the last session. He's particularly invested in decision-making regarding candidacy and end-of-life care. Natalie Rintoul doesn't need introduction in this group, but she's a senior neonatologist at Children's Hospital of Philadelphia, professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She's the medical director of the neonatal ECMO program and the neonatal surgical team, where she specializes in the care of infants with complex anomalies, such as congenital diaphragmatic hernia. She's contributed extensively to ELSO guidelines and clinical research aimed at optimizing neurodevelopmental outcomes for the most fragile surgical neonates. Team, if Jonah, I think you're up to start introducing the session.
Yes, thank you, Peter. It's my pleasure to start the session by introducing Dr. Roxanne Kirsch. Dr. Kirsch is a pediatric cardiac intensive care physician, chief of the Division of Cardiac Critical Care and Clinical Bioethics Associate at the Hospital for Sick Children in Toronto, an associate professor at the University of Toronto, Her academic work centers on the ethical challenges of advanced life support, including resource allocation and the discontinuation of ECMO. She is dedicated to enhancing clinicians' facility with complex ethical decision-making to improve the delivery of end-of-life care. Dr. Kirsch will talk to us today about how optimizing outcomes includes knowing when to start and when to stop. Thank you.
Thank you. Jonah, can you quickly confirm you can see and hear everything appropriate?
Yes, I can. Thank you.
Thank you for the great honor of letting me speak at this summit. 10 minutes for starting and stopping, encompassing most of pediatric and adult ethics is daunting, but I'm determined to try and make it happen. So thank you for the kind invitation. We're going to look at some considerations, and I'm trying to bookend it for start and stop, but they are inherently tied. So I think that this is actually a nice way of presenting it when you have to be super succinct about how we think through things. And there's no way you're going to start a legacy summit without coming back to the founder himself. So this is a lovely memory of many conversations I got to have with Dr. Bartlett. But one of my earlier presentations about ECMO and ethics, we were having a conversation and he said, you know what, Roxanne, this is going to be just like dialysis in the 60s, isn't it? And to a certain extent, it really is. And I actually never felt more seen because it was really how I had been approaching it and thinking about it. And the historical references to how we've used devices are relevant to how we take on device use today. Even though things change across decades, the way that we approach them can still be useful and helpful. And his key focus of kick it under the bed, or as I now sometimes state, once you can take ECMO home in a backpack, are we going to worry about starting and stopping the same way? Because for all the other devices, the easier it gets and the more you can get them out of the ICU, the less we worry about the starting and stopping. I'm not sure that's actually the right way to go about it, but that's a different topic for a different day. So just as a reminder, if you think yourselves back, and people will have seen this slide from me before, but dialysis was started in the 40s, it came into vogue in the 50s, we're using it regularly in the 60s, and we come up with these very dramatic headlines about how we had to make decisions with not having enough devices. But when you actually flip it and think about what's happening, these are candidacy decisions. So this is not actually a new problem that we're having. It might be a slightly different context. And we've now went from having these deep, dark candidates' decisions, difficulties of who deserves to get the device to, by the way, dialysis is travel ready. And I'm not sure anybody spends a great degree of angst in the majority of who needs dialysis decisions, and really focuses on those very specific cases in which it's unclear if it will make a difference or unclear of what benefit that you're achieving. And this is a normal pattern. So this is what we've been doing since the invention of intersection of medical device technologies and invention of ICU. And I've also shown this before, but I think it's relevant to why Dr. Bartlett framed that question to me. We talked a lot about starting and a lot about stopping with every device that we've ever used. And I say this in the sense that applied ethics we already use every day is still relevant and helpful. And I don't say that to pretend that you have nothing to worry about, but it's actually to encourage you that you have the tools to worry about the things with applied ethics in the same way that you always have. I'm sorry for the way this is projecting now, but it really is that we're more likely faced with some of the unresolved issues of some of the application of technology that we haven't used, meaning as we've progressed to technologies that aren't in the ICU, we have actually not necessarily solved the resource allocation of what the costs and to both humans and financially are outside of the ICU. So here we go, because I never not going to give you the ethical permissibilities and underlying justifications, but we use the same ones for starting and stopping. And you see this most often when we talk about stopping, but it is actually relevant for starting. These are the things that you're considering. We use the principalist system in Canada and the US, so that's largely where we're basing those considerations. But I want to draw attention to the allocation and initiation, because when I talk about stopping, I usually take that out of the puzzle to a large degree. But here's where you actually really need to live up to equitable allocation across patient population and systems. This is where fairness really comes into play. An individual patient that you're advocating for is always a tension with the entire population of what you're advocating for. And without keeping that in mind, you won't wind up with a fair decision. We, of course, always have the overarching best interest framework. And then across a period of many decades, we've had a legal canonization that allows for withdrawal and the parameters that that depends on. So I'm not going to dig into that further at the moment. So when it came right down to it, how can I tell you what the key issues are for optimizing starting ECMO in 2026? We talk a lot about indicate and contraindicate lists. They're not adequate. They can still be helpful. It's a nice place to start, but they're not going to be adequate when we're this good at ECMO and we can deliver it to nearly everybody under almost any circumstance. So I think it takes us to a different level of nuance and understanding what device we're using and how we're using it. This is when you need to examine your program capabilities and abilities. Providing poor ECMO is not better for the patient than providing no ECMO. So it really isn't just that PETA can do something in Boston, so I'm going to do it here. If you don't have the proper resources to make ECMO happen, then it's not necessarily appropriate for that patient to receive ECMO. This is true whether it's a device or a surgery or a medical indication. We just don't always articulate it that way. You need to consider your human resources. You need to consider candidacy across populations. And candidacy is then largely linked to outcome prediction. And this is when we often come back to, we want these indicate, contraindicate lists. But this is going to be less and less clear when you don't really have a lot of contraindications left other than technical and feasibility. So your volume, your experience and resources may be the centers that have these huge volumes that are always pushing the envelope. They may be the ones that need to do this at the edges use. That doesn't necessarily make it wrong for those centers who can solidly do the core of what we need ECMO for well. And I would advise that that's the way that it should be considered in that setting. There is a consistency of offering that is important. And additionally, you might consider what to offer, but then you ideally are incorporating patient and surrogate values when you're actually starting forward. It's not always going to be possible in an emergent decision, but it is more possible than we often consider in many instances. So starting ECMO, you need team-based decisions that are going to mitigate your bias. Because if we know, and there's a lot of literature, I did not place it all in my references here, but we know that we have a lot of inequities in who actually receives ECMO. So ideally, you discuss as many sort of broad group categories as you can in advance. You ideally are able to rapidly collaborate with some group that is ideally multidisciplinary in uncommon use cases so that you can understand if it's appropriate or not. And ideally, we document it all because the only way to review whether that decision made sense or didn't make sense, separate from how the outcome came about, was to actually put justifications. And we'll often have justifications for why we provided or why we're stopping. We also actually ideally are adding justifications for why we are withholding. The fair collaboration needs some consistency. I just point you quickly to Jonah's domains model, and I did not know he's my moderator, so I'm not just sucking up. But Jonah's article in AJOB 2025 is a quick read to understand what he's described as domains. And I think in this sense, this is what I mean by broad categories, so that you can discuss reasonably and not just shrug your shoulders and say, oh, they're not the right age, or if you're in peds, they're too tiny. So those considerations will give you a much more nuanced conversation. Of course, communications is going to always be important. Now, the reason domains can be helpful is that we've talked about a lot of bridges, and the bridges is a language that we use to try and understand your off-ramp for ECMO. But in usual setting, and the reason I have a picture of like a bajillion bridges is because the more we do, the more medical people will find a new medical name for a bridge to a something between a something, and then there's cross bridges, and then there's the other bridges. The point of the bridges conversation is not that you have to pick a bridge and stay on it. It was just a way to formulate what is your purpose of doing ECMO. So again, a bridge is only useful if you're doing iterative goal-directed review. What is the purpose of that bridge, or what domain of care are we in, and what outcome do we think we can accomplish? And always being mindful of circling about, pretending you're taking different bridges when you're actually not getting anywhere at all, and that you need to really face some difficult decisions sometimes in whether or not it's appropriate to stop. So in this instance, we talked about candidacy as an ongoing consideration. This is just a paper, but there's others that have said similar. And the reason we put it this way is just that it's often feels like, okay, this patient's a candidate, go time. And then you're on ECMO, and then everyone can feel committed to doing ECMO, which doesn't leave you and the patient in a good spot for reconsidering if there's still an ECMO candidate the next day and the day after and the day after that. So what we're looking at is how do you reevaluate the decision that you've made? This does not actually mean that you're consenting the patient to continue ECMO every day. It means that you're actually reviewing as a team, what do we think is the purpose of continuing onwards? Where are we headed? And you have some sort of communication with the family. And of course, depends on the duration of the run as to how frequent and what changes are happening as to how frequently you communicate. We do have a couple of communications guides. Pediatrics has two. This has led because there weren't any other communications guides on recent review, but it's important in all of those. And again, they're just expert guides, so there's more study definitely needed. But ideas behind that are having conversations about endpoints in advance and trying to keep focused on goal-directed care to move through those conversations. Almost all the systems, Canada and the US, and almost every jurisdiction is just disallowed to stop unilaterally by a medical team. So the medical team can't say stop and then proceed without family accepting that that's how we're moving forward. But most places should have some sort of policy to support how you navigate that scenario. Now, this should be very rare. So if it's happening frequently or the majority of your cases, then I think you need to come back to the other steps of how you're providing ECMO and understand which of the steps need to be more robustly addressed to minimize how many times you end up in conflict. That can take a lot of group self-reflection, and that's going to take a lot of open conversation and discussion. This is a resource allocation at the outset, but if you're stopping an individual patient, you need to be justified in the sense of how you justify that against the system and justify that against other patients. So it will be very patient focused on the benefit for that patient at the current moment, rather than the resources can't maintain it. But certainly in other locations, there may be durations or abilities that affect your resource allocation. Always would recommend bioethics consultation where available, and you're always going to need team support and communication. And I just want to call out a paper that's in press. So pull up your ASAIO. I don't know, it wrote 2023. I think that's when we started the project, but it's coming out in the next few months. And this was big working group to try and get to some practical considerations. So I was very pleased to be part of it, and I think that it'll be helpful. I've shown this in different forums before, but there's a lot of challenges to stopping that aren't just like, yes, it's time to stop. So consideration of all the influences helps you to move forward. I wrote about this quite a while ago, but others have written about it since, and this holds true for those of us who work clinically and in teams to try and move towards how do we understand stopping. And you'll notice that the family and the team misaligned is one corner of all the other pieces of the puzzle. So when I say review what pieces of the puzzle might be giving you difficulty, this may be a lot of other work to do beyond just, well, the family doesn't get it and it's hopeless and we can't get them to understand. So it is important to do all the other steps, and you will still wind up sometimes misaligned in your goals. So also not being too hard on yourself when that is evolving and happening. Navigating, starting, and stopping ECMO, therefore, is inherently a resource allocation decision. Starting and stopping are both at risk for bias, so reasoned and justified indications for goal-directed therapy are important. Consider your purposes. Discussing in domains, opening up the conversation to something more nuanced is simply necessary now in 2026 with the availability and capability that we have to do ECMO. You might want to consider a lot of different types of forums. Whatever works for your center is appropriate, but you need some sort of larger decisions where possible. And a lot of nevers or always should be eliminated to sort of reframe the whens and hows of doing something so that you're talking about more than just can and incorporating some should. Please document. The only way we're going to study, understand, and improve this is by all of us taking on the documentation and justifications that we need. We can't get by with lists of indicate, contraindicate, start, and stop, and we shouldn't. These are a highly complex system. We're interacting with highly complex humans, and it needs ethical, nuanced decisions based in collaboration, communication, and incorporation of views and values. Thank you so much for allowing me this opportunity to present.
Roxanne, that was incredible. I'm really looking forward to reading those publications. I can't wait to see them. It's my great pleasure to introduce now Dr. Tobias Straub. He's a pediatric critical care specialist and an assistant professor of pediatrics at Duke University. He's the co-founder of VQ Biomedical, where he led the development of a novel intravascular oxygenation device designed to provide lung support without the risk of traditional ECMO circuits. His clinical and research efforts focus on advancing minimally invasive respiratory support and improving outcomes for critically ill children through medical device engineering. Today, Dr. Straub will share his insights on intravascular membrane oxygenation. Thank you.
All right. Can everybody see and hear me okay? Very good. Okay, so I'm really honored to be able to speak here at the Bartlett Legacy Summit today. I'll be giving a brief overview of our intravascular membrane oxygenator catheter development. Before I begin, though, I'd just like to disclose that my colleagues and I, with the support of Duke, have with the support of Duke, have created a spinoff, VQ Biomedical, that serves as a vehicle for the ongoing research and development of this technology. So what is an intravascular membrane oxygenator? Well, like the name implies, it's a device that provides supplemental oxygen directly to the bloodstream while also removing CO2. So it's essentially a highly efficient membrane oxygenator placed on the tip of a catheter. It delivers oxygen and clears CO2 independent of the lungs. And so then, similar to ECMO, should allow for the reduction in the intensity of mechanical ventilation and reduction in FiO2. Because you put the membrane lung in the venous bloodstream and in the body, the membrane lung is therefore exposed to the entire cardiac output. And this more naturally recouples oxygen delivery with cardiac output. That is, if you have a patient who's receiving or has a membrane oxygenator catheter, if their cardiac output goes up because they're septic, well, this blood flow would then all more naturally flow past our catheter on its way back to the heart. Unlike VV ECMO, where you'd have to work hard to capture large portions of that cardiac output to pump it past the ECMO membrane lung. By putting the membrane in the vasculature, you also have a lot less foreign surface area in contact with the blood. It's only the hollow fibers that are in contact with the blood. There's no pump. There's no Tygon tubing or circuit tubing. And so if there's less polymer or foreign surface area in contact in the blood, the hypothesis is there's less inflammatory response and may need less anticoagulation with this device. Again, there would also be no pump. This would be a passive device ideally. So the venous return as it flows back to the right atrium would just naturally flow through and around the hollow fibers. And with no pump, therefore there should be also less hemolysis. So I think there's a lot of reasons why this approach to membrane oxygenation is quite an attractive way to provide supplemental gas exchange. So how do we go about doing this? Well, our approach is novel. There's been many other groups in the past who have attempted this. The IVOX catheter from Mortensen out of Utah, the Hattler catheter with Fitterspiel from Pittsburgh. And they made some intravascular devices that had some preclinical testing, and even the IVOX device had clinical trials. And they were able to deliver some gas exchange, but they inherently relied on a whole lot of hollow fiber membrane surface area to have sufficient gas exchange. And that created really large, bulky catheters that were up to 48 French in size, were very impractical, limited venous return back to the heart, and just struggled. So what do we do and how is it different? Well, we use pressure enhanced diffusion through non-porous polymer hollow fiber membranes. So that pressure enhancement allows for oxygen to diffuse down the pressure gradient and diffuse into the wall of the hollow fiber polymer and into the venous blood surrounding it. We couple this with angular oscillation, so some gentle oscillation of the hollow fiber bundle to further reduce boundary layers and increase the efficiency of our device. And so these two things coupled together in our device have resulted in the highest oxygen transfer efficiency published in the literature. And here's just a quick engineering schematic of how our device works. So our catheter is represented by these green hollow fiber bundles. Over here on this side, on the right-hand side of the screen, is the shaft that would exit the venotomy and out of the skin. So pressurized oxygen is flowed down the central shaft through the distal end cap, where the oxygen then flows through the green hollow fibers on its way back out to the outlet. And as that pressurized oxygen flows through those hollow fibers, again, it diffuses into the wall of the polymer and into the venous blood that's flowing passively by and through the fibers. So, well, where are we now? So we coupled this hollow fiber bundle system with a protective cage and containment system that helps center the device within the vena cava and also protect the delicate venous endothelium from the oscillating fibers. And so here's just a quick schematic of our hollow fibers, which in this photo are represented as gray, and our nitinol cage that is surrounding the hollow fibers in the current iteration of the device. Here's another engineering schematic just showing what it actually looks like. So our catheter right now ranges in size from 25 French up to about 32 French, including the containment system. And it needs to go in narrow, ideally as narrow as possible, to be as small of a catheter as possible. But once in the vena cava, we need those fibers to expand and deploy across the diameter of the vena cava to help spread and deliver the oxygen more efficiently. And so what we've come up with is this system of collars that hold the fibers in this kind of bowed configuration, such that they, upon retracting a sheath, pop out and deploy nicely across the cross section of the vena cava. And here's a photograph of what our device actually looks like in one of the recent generations of prototypes. So you can see the white polymer hollow fiber segments, the collars, and this flexible shaft that allows it to traverse the vasculature. The whole device fits in a sheath, and upon retracting the sheath, the fibers deploy and expand. And within the sheath, it's very nicely flexible and, again, can traverse the anatomy. So, well, how much gas does our catheter exchange at this point? And so to answer that, we have a nice in vitro benchtop system that's, we do all our tests in accordance with ISO 7199. And so we pump porcine blood past our catheter, which is kind of in an anatomical mock vena cava. We pump it at about 5 liters a minute, which is roughly an adult's cardiac output. And we can simply measure, the inlet and outlet concentration of oxygen and CO2 of the blood. We actually use ECMO membranes to deoxygenate the blood so we can have a continuous loop and keep everything in equilibrium, such that the inlet saturations of the blood passing by our catheter are about representative of the mixed venous sats in the body. So once we got our in vitro setup up and running and better understood what our catheter was capable of, we began testing this in large animals. And so the in vivo feasibility studies that I'll quickly describe here are ones that we just completed in the fall of 2025. And so for these studies, what we did is we took 80 to 90 kilos of large Yorkshire pigs, and we did a surfactant depleted saline lavage ARDS model. So the pigs had an acute hypoxic lung injury. P to F ratio was less than 100. And the compliance and pulmonary mechanics of the lung injury was very representative of a severe ARDS. So once the pig was hypoxemic, we performed a venotomy when we placed the catheter over the wire using fluoroscopy. And the catheter would sit via the jugular approach in the same bicaval position as any of the dual lumen bicaval ECMO cannulas. So here you can see in this photograph, this is a transhepatic ultrasound long axis view of the vena cava. So the liver is up here, the white arrow is the hepatic vein, the right atrium is here on the right-hand side, and the red arrows point to our fiber bundle catheter within the abdominal inferior vena cava. And so it was exciting to get the catheter in place. We would turn it on, and within minutes of turning the device on, the pulmonary arterial oxygen saturations would pop up by 4 to 7%. And we were able to deliver as high as 74 milliliters of O2 per minute within the vena cava of the animal. And we did this with, generally reassuring markers of safety given that it was an early prototype. So we had stable hemodynamics, the cardiac output did not change, the blood pressure, the central venous pressures did not change. We were not blocking blood flow as the blood flowed naturally back to the right atrium. Importantly, there was no evidence of gaseous microemboli during routine operation of our device. And so what are we doing from here? This is just the beginning. Well, we've got another generation of prototype already made and developed that we're looking forward to test in subsequent large animal studies that can deliver greater than 100 milliliters of O2 per minute, and is anticipated to be clearing greater than 30 mLs of CO2 a minute. And so we're continuing to increase the gas transfer efficiency of our device, both oxygen and the CO2 clearance. And we'll be quantifying the improvements in systemic oxygenation in our large animals that are upcoming and seeing how we'll be able to turn down the ventilator when we use our device. We've got some safety survival animal studies coming up at the end of the year and into next year. We're, of course, working on antithrombotic coatings and continuing to optimize the cage and sheath delivery system so that it's as easy to place over a wire using the Seldinger technique. Ideally, it can be placed at the bedside. So in conclusion, our catheter membrane oxygenator already has the highest oxygen transfer efficiency published in the literature. And because it's so efficient, it can be smaller. We're 4 times more efficient than currently marketed ECMO membrane lungs. Going forward, our goal will be for our catheter to be able to deliver greater than 100 milliliters of O2 per minute, while also clearing about 50 milliliters of CO2 per minute. And I believe with that, we'll be able to turn down ventilators and perform more lung safe and lung protective mechanical ventilation. And so, my vision for the future is let's be able to deliver oxygen and perform gas exchange directly in the bloodstream without having to pump patients' blood out of their bodies. And I realize this is a bold vision, but I feel like this is the logical next step of where the field is going in the coming years. And I'd like to nudge the field in that direction. Thank you again for allowing me to speak briefly. What an honor it is.
Dr. Straub, thank you for that presentation. Very interesting stuff. I'm sure we'll have some questions at the end in our Q&A. Our next presenter is Dr. Jonathan Haft, who is a cardiac surgeon and professor of cardiac surgery at the University of Michigan, where he serves as the medical director of the ECMO program. A past president of ASIO, his clinical expertise centers on advanced heart failure, transplantation, and the surgical treatment of chronic thromboembolic pulmonary hypertension. Dr. Haft is a past ELSO Technology Committee Chair and current member of the Board of Directors at ELSO. He has led research focused on developing novel devices to improve organ preservation and reduce complications in critically ill patients. Today, Dr. Haft will share his experience regarding regional policy advocacy. Jonathan, take it away.
Thank you, Justin, and thanks to the committee for inviting me to talk about something that's very different than the remarkable presentation that we just heard. So I'll just dive right in. Can everybody see my slides? Justin, can you give me a nod? Yeah, good. All right. So, I certainly recognize that ECMO is global therapy and ELSO as an organization is international, but my talk, with apologies, is US centric because that's what I learned through my experience. But I do think that many of the principles are applicable to wherever you may be. So what exactly is advocacy? What does it mean? So it's really public support for a cause or a policy. So advocacy could be commissioning research, it could be educating the public, it could be creating coalitions, or it could be working directly with government entities or some other oversight body. Now, many professional medical societies employ advocacy firms, and I can assure you, hospital systems, industry, and insurance companies all definitely employ advocacy firms. And the reality is that we don't always have alignment of our mission. And often that misalignment is about money. And this is not a talk about greed. It really is a talk about ensuring that we have resources to do the things that we think are important for our patients. So US healthcare, I am not an expert in the quagmire of the US healthcare space, but I'm going to give you some very broad strokes for those of you who don't know much about it. So who pays for healthcare in the US? So 30% of it comes from private insurance that citizens either purchase or insurance that's provided to them through their employment. 15% of healthcare comes directly out of the pockets of US citizens, and the rest of it comes from the government from a variety of different mechanisms. The most important mechanism of government-sponsored healthcare is CMS, the Center for Medicare and Medicaid Services. So Medicare is health insurance, government-sponsored health insurance for the elderly, the disabled, and those with renal failure. And Medicaid is health insurance for poor families. So how does CMS reimburse hospitals for episodes of care? Well, they don't just pay whatever hospitals charge for it. They pay what they think is appropriate. And patients are assigned a code, a DRG, Diagnostic Related Group Code. And there's thousands of these codes. And these codes determine how much a hospital would be paid for the services they provided for a patient that has Medicare or Medicaid. The payment, of course, is prorated based on, cost of living. So you may get paid more, for example, in New York City than you would in maybe parts of rural America where the costs are very different. Now, the DRG code that a patient receives is based on these very complicated algorithms that incorporate diagnosis codes, what's wrong with the patient, and procedure codes, what sort of therapy did we provide for the patient. Private insurances have their own algorithms, but oftentimes, if there's significant changes in how Medicare treats patients, the private insurances tend to follow. So what does all this have to do with ECMO? Well, ECMO is expensive, right? The equipment is expensive. The labor is highly specialized and expensive. And even on top of those things, hospitals that do a lot of ECMO, they have built a very established and robust infrastructure, which costs money. And then most importantly, the patients that we put on ECMO are very, very sick, which means if they survive, they often spend a long time in the hospital. Hospital length of stay is by far the most powerful driver of cost of delivering care. So prior to 2018, how did ECMO get reimbursed by government-sponsored health insurance? So as I said before, a DRG is assigned to an episode of care for a patient in a hospital. Now, that DRG is based upon diagnosis and procedure codes. Anybody who was initiated on ECMO prior to 2018 was given a procedure code that you see there. That was the same procedure code whether you were a baby or an adult. It didn't matter what your diagnosis and why you were on ECMO, and it didn't matter how you were put on ECMO. But that one code automatically led to an assignment to DRG 003. It didn't matter, again, what your diagnosis or what other procedures were performed. Everybody on ECMO got DRG 003. And it happens to be that DRG 003 was among the highest reimbursing codes for CMS. In 2018, the average was about $100,000. And that's money that hospitals need to cover the enormous costs associated with taking care of these really sick and complex patients. Now, CMS recognizes that healthcare is changing. There's new ways to treat patients. There's evolving costs, and they want to keep up with the times. They change their codes on a regular basis. They have open forums where they recognize we're not the experts. Let the experts come to us and tell us how we should evolve our codes over time. Now, these open forums are attended by industry, hospital, and physician group advocates. If CMS says, we think we're going to make a change, they put it out there as a proposal, and then there's an opportunity for the public to interact with these proposed changes, and then CMS makes the final change based on what they interpreted. So the process is really supposed to be transparent, and it's supposed to be inclusive. Here's an example of a timeline. You can see here the IPPS is the Inpatient Prospective Payment System. This is basically how much you get for the different DRGs, and it is proposed in the spring of every year. And then there is a 3-month comment period where people can then say, we think this is a good idea, we think this is a bad idea, and then CMS will make their decision, which is implemented in October 1st of that year. So what happened with ECMO? Now, what I would say is that there was no proposed change in the DRG for ECMO in 2018. There was a lot of discussion about procedure codes during a simultaneous process where, again, there's open forums and opportunity for public comment. So there was a presentation in 2018 at the Procedure Code Open Forum where somebody said, you only have one code for ECMO. And it doesn't differentiate the different types of cannulation, whether it's central or peripheral. You should have separate codes for that. And the presentation also suggested that it is a marker of complexity and therefore associated cost for the patient. So CMS responded and said, well, we think this is a pretty good idea because cannulation is different. We should have different procedure codes. So they created 3 different procedure codes. And those different procedure codes were then assigned to different DRGs. Central cannulation remained assigned to DRG 003, again, that very high payment that hospitals need. But the remainder of the DRGs went to the remainder of the codes went to different DRGs with dramatically reduced payments, as much as 1/15 of the original payment. For my own hospital, we estimated a loss of revenue in 1 year of about $5 million. So pretty significant change in revenue for this complex group of patients. So I didn't find out about this because I read these government registers. I'm just a doctor. But I found out about it from an industry rep, somebody who sells us ECMO products, who said to me, "Hey, Dr. Haft, what are you going to do about this huge reduction in reimbursement for your hospital for ECMO?" And I said, "A what? I don't know anything about this." Now, it happened to be in the fall, and it was right before the ELSO meeting, and I sat on the steering committee, and I brought this up at our steering committee. And the response among all the physicians on the steering committee for ELSO was, "A what?" Nobody knew anything about this. ELSO did not really have an advocacy arm and was not prepared for this. And so our president, Mark Ogino, said, "ELSO absolutely has to respond to this. We have to do everything we can to try to reverse it." And he put me in charge. I have no idea why. I had no qualifications for this. But I am a cardiothoracic surgeon and an active member of the Society of Thoracic Surgeons, and they have an advocacy arm that represents the interests of the STS. And I spoke to the president of the STS at the time, Keith Nonheim, who was not an ECMologist, doesn't do ECMO on a regular basis, but he recognized that ECMO was really important to cardiothoracic surgeons, and anything that would reduce their ability to do it is a huge problem. And so he allowed the advocacy arm of the STS to really take the lead for this. And so what did we do? The first thing was, are we right? Is the concept that central versus peripheral cannulation should be associated with different complexity and therefore different associated costs, which of course it's not, right? We all know that. The second was to build a coalition. So our advocacy experts said, the government listens, but they're more likely to listen if it affects a broader population. And what could be more broad than ECMO, right? Babies, grown-ups, a variety of different problems. And so we got almost 30 professional medical societies to completely support our efforts. And then the last was to understand the process. How do you, get CMS on the phone and say, "We think you made a mistake here"? And so here we are, March on Washington. So basically a group of physicians, and this is Courtney Yo. She is the advocacy expert who really is a brilliant woman and knows how to navigate the complexity of the US government. This is the Department of Health and Human Services. And we went in and we made our pitch. And sure enough, we were effective. So what you can see here was the proposal in the spring of the following year. The new procedure codes that previously went to different DRGs are now all going back to DRG 003. So they restored the previous reimbursement for ECMO. So crisis averted. Right after the proposal in the spring, ELSO for the first time got into the political game and decided to respond to this in the public comments and basically said the idea that mode of cannulation is somehow associated with cost and complexity is just factually incorrect. So Dr. Bartlett, he didn't come with us to Washington. He wasn't directly a part of this. But what I would say is when we made our pitch, we had like a 15-minute elevator pitch to CMS. We were very scripted in how we were going to deliver this message. And the anchor of our rotation, physician, talked about inequity of care. And he said, different hospitals and health systems, there's variability in practice. And often that variability is because of unique pockets of expertise and passion. And the University of Michigan, for example, has Dr. Bartlett, right, with expertise and passion for ECMO. And so regardless of what the reimbursement is for ECMO, it's likely that hospitals like the University of Michigan are going to continue to provide care, whereas other hospitals just can't take the financial hit and will not prioritize ECMO, which means you're going to have some hospitals that are more willing to do it than others. And that's inequity for care. And I think government representatives are very sensitive to that because what the government is supposed to do is provide a safety net for those people who need it. And the ECMO safety net was removed with their policy change. And I think it was a main reason why we were effective in making this change. So Dr. Bartlett wasn't with us, but effectively he was. So importance of advocacy. This is policy impacts care. That is just a simple fact, whether it's through, finances and reimbursement, whether it's medical legal issues, whether it's coverage and patient access, credentialing, approval of pharmaceuticals and medical devices. All of it is important to the way we care for patients. And there is expertise in predicting and responding to policy changes. And the fact is that most physicians don't have those skills, right? It's not what we were trained to do. And so in my humble opinion, I really do think our professional medical societies should work with these advocacy firms that have these skills, because it will impact how we care for our patients. So thank you very much for the opportunity, and look forward to the future talks.
Jonathan, thank you so much. The opportunity to have a North American focused advocacy talks was just too good to pass up today, because unlike our global conference that's based in North America, we are a North American focused session today before we kick off the rest of the globe for the 24-hour meeting. So thanks so much for spending the time helping us understand better the events as they transpired and turning that around. Next up, somebody who knows all about the global conference that we host as ELSO in North America, Natalie Rintoul. Thank you for joining us to share your insights. Natalie is the current ELSO Steering Committee Chair of the conference, and you'll know how fabulously successful she's been. Today, she's going to share her insights with a talk titled Shared Opportunities for Learning, the Power of a Global Conference, to wrap up our North American regional session of the Bartlett Legacy meeting. Thanks so much, Natalie.
Thanks, Peter. Okay, let's just see here.
You can see the share at the bottom of the screen, buddy?
I can, yeah, and I'm, yes. So this is, I thought this would be absolutely fine. My computer does not like Zoom. Let me just see here.
I'm sorry I didn't think of this earlier, but if you wanted to share your presentation, either one of the ELSO team or I would also be happy to share your slides.
No, thanks so much.
Yeah, do you want to email it to me, Natalie?
Yeah. You know I have difficulty with, I just thought that this would work. Oh. Sure.
You've emailed the slides, Natalie? Yeah. While we're waiting, maybe you can give us a preview. I know that you and the conference committee have already done an enormous amount of work for our September conference. Is there anything that you're willing to share?
Well, the conference is going to be amazing, and it's going to be in Nashville. And that if you've not been before, it's a really neat place. And the conference center is very close to the Grand Ole Opry, which is, has a lot of history. So the conference itself, the content is shaking up to be amazing, and the location will be incredible. So we're really hoping that a lot of us will be able to make it there. It's always, again, putting this together, it's always hard to think of the positives of a conference, but knowing that it sometimes is difficult to travel. But really the positives of an in-person experience and the ability to speak to people outside of the formal lectures is really so incredible. So if people are able to, we definitely would encourage that. And we do look forward to seeing everybody. So that's end of September, the 28th through October 1st. So it's going to be incredible. So Christine, do you have my slides?
Don't have it yet.
Oh, goodness. Let me just see if I can.
I'm refreshing my system just to see if I can speed that along. Or I wonder if you want to try it one more time, Natalie.
Yeah, what's happening? I'm getting all these privacy settings coming up.
Okay.
So I thought it was good that I was able to join. And so I thought
Really
that
good.
that would be fine. My hospital doesn't support Zoom, but then I was super excited that it allowed me to do this.
We're doing this all in the public forum, but you can see that your slides have left your inbox and are making their way to Christine for now.
Yes.
Okay. Any news on who the plenary speakers will be, keynote speaker?
Not yet. We have some exciting possibilities, but we're still working on it.
You shouldn't share that sort of thing in public anyway.
Yeah,
I'm just trying to see what I can get out of you.
yeah. I know. I'm about willing to share just about anything since I can't like log in here.
Except your slides.
Oh dear.
Is there, would you be comfortable just speaking to the importance and the impact of the conference without your slide?
Absolutely. Yes. Yes. So I think that, what to me is so significant about a global conference, and again, like I'm biased being the conference chair right now, but it's the ability to share experiences and what we know in a very personal way, with slides and conversation and again discussions in hallways. And so I think that this really did stem a lot from the culture that Dr. Bartlett brought to all of us, in terms of his willingness to share and teach at bedside. And, I was reflecting that those were sort of probably the very first conferences of sorts, right? With him sharing at bedside and having people travel to him to see what he was doing. And so I think that those are very powerful, powerful things that Dr. Bartlett taught all of us, to be honest, in the culture of sharing and learning together. And in addition, really the power of the ELSO registry in creating data and the ability to have experiences that could be shared in terms of numbers and diagnoses. So the conferences are incredibly important and will continue to happen. One of the things that we wanted to discuss today was, the future. And I think the future of these conferences, in the spirit of Dr. Bartlett, is to, number one, have them continue. And we are sort of a small group, much smaller than some of the other international committees and groups that work together, have them continue and foster collaboration and discussion and thoughts, but also, think about new ways to have more people involved. Some of the conferences, we've been able to have upwards of 2,000 people join us in person, which is like amazing. But when we had to go virtual in those very tough years during COVID, we had multitudes more. And so what we want to do is be able to find out ways to really encourage our partnership in working together, but also to extend our reach to people in areas of the world that aren't able to travel and don't have that luxury of time to leave their institutions and to travel and join us. So I think the future is ongoing collaboration and working together and finding new ways to do that, but to continue to continue our commitment to working together and collaborating in the spirit of Dr. Bartlett. So maybe we could have a great conversation. I know there's lots of discussion points that are circulating here in the chats that want to hear and ask questions with the other speakers as well.
I think that's a great idea, Natalie. Thank you for sharing some of your insights. I agree that how we as the global community and the interprofessional team that's imperative in providing ECMO care look to the future for what conferences mean and how we navigate the distance and global political climate is going to be enormously important. So thank you for thinking about all of that together. If I can just invite the speakers from session 4 from North America and the moderators to jump back on screen, we can kick off our Q&A session now. And I can see that Dr. Haft is already up for a question. Go ahead, friend.
Well, I was just going to fill the dead space. I have a question for Natalie. This is your 3rd year doing the ELSO conference, which is just an absolutely enormous task. What have you learned? You tend to get better at things when you do it over and over again.
No,
what have you learned that you didn't know your first year?
No, it's so true. Well, I didn't know that, number one, Christine and Peter are like phenomenal, magical people who seem to have 24 hours a day, the ability to have normal lives and also respond and come up with great ideas, and that they're not scary. Like I did think, they were these people that were the leaders of ELSO that, people think, well, I'm nervous to email Peter. I don't want to ask Christine. And in fact, they're just incredible visionaries and so committed to this program and important to the mission and to maintaining what Dr. Bartlett set out to do. So that was really something that has just been an absolute pleasure to discover working with this team. And even, the project managers, Alex and Janelle and Lauren, have been just phenomenal. So I think that, you think a big conference would have thousands of people working on the bits and pieces. And in fact, no, it's just like a handful of people behind the scenes, but just incredibly hardworking and very committed. I think that realizing too how many people put their heart and soul into this, and it's not part of their daily job title, it's incredible to me that people will just reach out with ideas or put sessions together or send talks together when that's, they're not their primary job. So I think what has been most impressive is that people are really committed with their hearts. They're loyal to the cause. And it really has been heartwarming and an incredible, no pun intending, but, just an incredible experience to meet everybody and to see behind the scenes and to really be part of just an incredible organization and an incredible cause, because it crosses so many disciplines and so many different types of specialties, and we all come to the conferences and we learn from each other. So it's really been an incredible experience. So thank you for asking that. That wasn't in my talk, but I'm happy to share that. So that was great. So
thanks, Natalie. I can't speak further to the importance of the ELSO office and Christine and Peter's leadership in bringing all of the ELSO initiatives through. I can see Christine's got her hand up.
Well, Jonathan, I appreciate that you asked that question of Natalie to kind of help save her. But of course, she doesn't need saving, and she didn't even need a presentation. And I hope what people feel through your own personal experience with Natalie is she's done such an incredible job being inclusive and pervasively welcoming. The conference committee has almost 100 people in it that help us plan for this. And it's just amazing to have this group of what Dr. Bartlett said, even in his instructions about how to celebrate his death with his marvelous friends, which of course all of you are. And that's how Natalie's done such a lovely job convening the conference. And I hope you all feel that way when you're able to participate with it. So Natalie, we're so lucky to have you in this role.
Thanks, Christine. Justin, I can see your hand is up. Have you got a question for someone other than Natalie, or are we just going to grill Natalie for 10 minutes?
No more for Natalie, unless she like that. But just questions for our speakers. I'll start with Dr. Haft. Dr. Haft, I was with you in 2018 with this coding hysteria or confusion really was happening. And you talked about the efforts at that time. Now, as a clinician, a patient advocate here at our hospitals, what can we do now in the present time? You talked about the steps to communicate, educate, government, industry, clinicians, but what can we do now to alleviate some of those concerns and kind of improve the pathway forward for our patients?
I mean, this is where I think your professional medical societies speak with a very powerful voice. And so you're a member of your perfusion society, which, by the way, joined our consortium in 2018 to help reverse it, which was much appreciated. But, they have a very powerful voice. And then, other professional medical societies, they're very effective at communicating, the interests of their group because they speak on behalf of patients. And, what could be more important than that? So staying connected to your professional societies, that's part of what they do.
I'll take a moment to ask maybe actually a joint question to both Tobias and Roxanne, because Roxanne began talking about how candidacy decisions might change when we get ECMO in a backpack. And so Tobias, I'm curious, do you envision this becoming eventually, this fascinating technology you described, do you envision this becoming an ECMO in a backpack? And then if Roxanne, you can follow by how that might actually change some of the ways we think about candidacy decisions. I'd love to hear it.
Yeah, that's a great question. Thanks, Jonah. I think, I look to the Impella a lot on how that changed mechanical circulatory support, what used to be VADS and extracorporeal, and now as a catheter-based device. I feel we're working to put the membrane lung on the tip of a catheter. And so while it's less invasive, easier to use, I still, at this time, envision it being used in a hospital setting, likely in a highly monitored environment such as the ICU. But my hope would be that, the complication rates from our device, should be less than ECMO, given the benefits. And so the threshold to use it should be maybe lower, and therefore, in less sick patients are receiving, the central venous line that diffuses oxygen into the blood. And so I do think it could and maybe should change the calculus of the risk-benefit balance and when to provide such support.
So tomorrow we won't necessarily be hearing about patients who are on home 3 liters intravascular cannula, but maybe.
But maybe, yeah.
Okay, and so Roxanne, if we do get that backpack, how is that going to change the way we think?
I mean, I think it will track along the ways it always tracks with humans. So my first one is practical. As soon as we had a long-term ventilator, we suddenly went, well, maybe it's not such a bad idea to do a trach and send them home. But a lot of patients didn't actually go home. A lot of them are going to chronic care facilities, especially in pediatrics. I can't speak to adults, but I'm imagining it's something similar. And we transferred the costs out of the ICU, and then all the intensivists stopped having big debates about the cost to society and the cost to the ICU. But we haven't necessarily accounted for it from a resource allocation system properly. So I suspect we'll do the same thing. I'm always ready for us to rise to a new challenge and perhaps do something different. But there is something to how Tobias described it, which is if it is simply easier and you can actually use it as a destination, then the possibilities for how you use it have changed. And then it is ethically appropriate to expand your possibilities for use because your device is now safe. And so a good proportion of the I'm stuck and we have to stop, even though things could otherwise be okay, except gosh darn, you just got this big circuit that you're dependent on. It is a bit different with it if you know that your circuit isn't eventually going to fail. And some of the stuck points with this circuit is going to eventually fail. You don't want to stop, but it's going to stop at some point. This is unpredictable. We all have a lot of angst. That should ideally be able to fade out. It's not necessarily the correct way to solve the you disagree with me, so we're just going to switch to the longer term device so we don't have to talk to each other anymore. I'm being a bit facetious, but just to sort of point out how we often go. It's not the right way to make that decision. So I'd like to hold us to making appropriate recommendations moving forward very carefully, but that is going to change how we're able to move forward. And then as soon as how you move forward, notice how I started with the ND, it does affect how we begin, because then you suddenly have a bigger range of who might possibly benefit. And then I can't be a good pediatrician without pointing out that much like the Impella, which has helped me out about almost never, we don't tend to design devices that actually fit children and neonates because they don't make money for the companies. And so children, once again, get left behind as the technology evolves. We end up jimmy rigging some adult device into tiny people and figuring out new ways to use things. And while I love the creative and innovative spirit, it is actually something that could use a lot of support from adult teams advocating to downsize devices so that children and babies can have some of the same benefits, because their quality of life years achieved almost always will exceed any adult device use indication, and what they can move on to contribute and how far they can take the technology teaches us how to use better devices. So there's my pediatric plug, and that's why we should consider how we marginalize peds just in the way we go about things.
I want to double down on that for a second, not just because I'm a pediatrician, although obviously I am, but also because miniaturization of devices is better for everyone, right? Like the original pacemakers would no longer be acceptable for adults either, and yet miniaturization of the devices that we're talking about is seen as marginalized for children. I think that that's a flaw in thinking and innovation. But that's just a personal opinion as a pediatrician. I can see Dr. Haft has got another question. Bring it on, Brend.
Well, I echo the comments about how children are marginalized, mainly because of the market forces and lack of profitability. I want to ask a question to Tobias about your the latest version of intravascular oxygenation. What is the non-porous material that the fiber is made of? I assume it's polymethylpentene, but I'm curious what it is. And then what do you assurances do you have that non-porosity couldn't be damaged over time, putting you at risk of air embolization from intravascular location?
Yeah, great question. So first of all, I'll clarify, our device is not intended to be implanted long term. It's not, maybe one day, but this still is an acute short term, device. So our polymer, it's a non-porous polymer, similar to common fluoropolymers already used in medical devices. It is indeed non-porous, and so we haven't seen any fouling over time. We've done a lot of reliability testing on our bench, but it absolutely cannot degrade, given that we have, some super atmospheric oxygen flowing through it. And I'll say our device, kind of integral to the catheter, is the control unit that can meter the oxygen flow and pressure through the fibers and instantly detect if there were to be a convective leak. We obviously can't have a bubbler in the vasculature for obvious reasons, and so that's inherent to its design. That won't happen and can't happen, obviously.
May I follow up on that? Of course, the Impellas that don't help Roxanne also, of course, are designed for a short period of time, and we use them longer.
Yeah.
Most patients who are on ECMO are on it for more than a day. So a two-part question here that are the same. But so are you envisioning though that over time will demonstrate that it's more durable and it'll be able to last longer? And then also maybe there would be an application. Do you envision an application where we might use this device instead of, let's say, mechanically ventilating, in a case where like you might even think that the ventilation might only be for a day or two, and where this might be less invasive to a point where it might actually make sense from a risk-benefit perspective to prioritize this?
Yeah, great question. So I'll start by answering the first. It's going to be engineered to provide support for days and days. What the regulatory pathway will ultimately look like may be different than what it's designed to do. If we know folks, for example, our target population is ARDS. We know how long patients are on VV ECMO for ARDS patients. So at minimum, it has to be able to function that long safely. But I think coming right out of onto the market, it's not going to be something that we expect to be in place for months and months. Down the line, in years, I hope that the device is improved such that it could be, and that might be an option. And then with regards to your second question, that's an intriguing question, and it's a bold statement. Can we replace mechanical ventilation with this? Uh, I'd love to. Yes, I'd love to. We're obviously limited by the size of the vena cava, and the physical constraints on how big of a membrane bundle we can put in there and how much gas exchange. But now with high flow being such improved, for example, or non-invasive modalities, I think in mild or even moderate, but certainly mild ARDS patients, there could be a segment of the population that you could support them with the non-invasive modality and put in this, large central venous line and supplement their gas exchange enough to avoid intubation. And in fact, that'll be an ultimate goal for ours.
Tobias, a question. Of course, I think about kids and pediatrics a lot, and definitely a positive of good technology in our space, which everyone is talking about. Just curious, though, I saw 5 liters of flow in the lab that you're working on, anticoagulation, concerns of that. What is the kind of the mixture of anticoagulation with your passive device?
Yeah, so right now, when we do our swine studies, we fully anticoagulate them because our device does not yet have antithrombotic coatings, the fibers themselves are nice and are very biocompatible. Again, we don't see any fouling of the fibers or thrombosis on the fibers. Sometimes on the end caps of the catheters, we will, and so we do anticoagulate. We'll need long-term animal studies to answer that. So, my goal would be to use less than, full anticoagulation, but we may have to. And then with regards to scaling it down to children, I am a pediatric intensivist, so that is near and dear to my heart. And, this work all started out of actually a neonatal patient that I had on ECMO who had a poor outcome. And so this will be used in children one day. Not first to market for all the obvious reasons that everybody said, but I can very easily scale the fiber bundle up and down and size it, and that is very much going to happen.
Would you
Wow.
would there be more colors along the length, or how would you improve gas exchange on a smaller catheter for pediatrics?
So it'll be a function of packing density of the fibers, basically, and some kind of way that we do mixing and novel mixing within the vena cava.
Wow. Thank you all for another fantastic session to wrap up the North American region of the virtual Dr. Bartlett Legacy Summit. The mixture of creativity and curiosity driving innovation that's been represented by this group really is core to what Dr. B would have had us thinking about today. The build of education, the collaboration of the conference, and the advocacy at the societal level are all the impact that we as a global organization mean to be delivering. And I really appreciate the time that you've spent with us today. Next up, I think we get a 15-minute bio break, grab some lunch, breakfast, dinner, wherever you're up to in your part of the world, and then join the SWAC ELSO team for the next 4.5-hour session as we follow the sun across the globe and finish up tomorrow morning, my time, with the Euro ELSO team. Thanks so much for making this a really successful first start to the day.
Thank you.